Good morning, everyone, and thank you for joining us for the Medical Board of California quarterly board meeting. While this meeting is being conducted with all board members and staff at the Sacramento meeting location, this meeting is being streamed interactively using WebEx to allow for remote public comment in the same manner as recent meetings. Public comments will be heard for each agenda item for each individuals wishing to do so, in person and remotely. To be ready for remote public comment, we ask you please ensure that your comments can be heard clearly by being connected to the audio of this meeting through the proper method. If you're having difficulty hearing the audio of this meeting, it could be because the device you're connecting with has bandwidth limitations. If you do have difficulty hearing the audio of this meeting using your device, please click the ellipsis button at the bottom of the WebEx application or the audio and video menu item at the top of the WebEx application, and then select Switch Audio. You will see an option to call in and will be provided with a telephone number, access code, and an attendee ID that can be used to connect to the meeting audio via phone. Using the information provided, it will automatically disconnect your device's audio and connect your phone to the name you joined the meeting with. By using this method, if you are having audio problems with your device, this will still allow you to participate and hear the audio of the board meeting. Please see the View Additional Meeting Information link on the first page of the meeting agenda for more information on connecting to the meeting and accessing meeting materials. Thank you. Vice President Hawkins, you can now start the meeting.
Thank you. Good morning, everyone. First, I want to apologize to the WebEx public for a technical difficulty we had yesterday. It's on green. Hear me better? It's on green. Yes, Dr. Hawkins, Vice President, Medical Board. You're okay? Oh. I may have to apologize again. Good morning. Apologies to the public on WebEx. We had technical difficulties beyond our control. We believe we solved it. I appreciate your indulgence. I want to ask all of us to please turn our cell phones to silent. You may notice board members are accessing our laptops, phones, or other devices during the meeting. They're using their device to access board meeting material that is in electronic format. If you're a member of the media and request assistance or information, please see Ali Sembra, who just raised their hand. We have a designated time on the agenda for public comment, and we'll ask for public comment on each agenda item. This is an official meeting of the Medical Board of California, and disruption of the board's business will not be tolerated. Government Code Section 11126.5 allows the board to remove people who willfully interrupt a meeting and clear the room if order cannot be restored, removing the disruptive people. The board welcomes public comment on any item on the agenda, and it's the board's intent to ask for public comment prior to board taking action on any agenda item. If for any reason I forget to ask for public comment on an item you wish to speak on that, you want to speak on that item, please raise your hand or come forward and you'll be recognized. This meeting is also being streamed on WebEx. Individuals attending the meeting remotely via WebEx will have an opportunity to provide public comment and will be assisted by the host who will be facilitating the WebEx meetings. The host will let us know if there's any problem on WebEx. During each agenda item, the host moderating this WebEx event will activate the raised hand and Q&A feature of WebEx. We'll ask anyone wishing to make a public comment to indicate by raising their hand or entering yes in the Q&A window. The host will then call on the individual who indicated they wish to make public comment by name, provided the individual, which may be a pseudonym. When called upon, the host will unmute the microphone of the individual, and they will have 3 minutes to make their public comment. But this time period may be reduced depending on the number of people who wish to speak, so that more people may be heard. The host will audibly announce when 30 seconds remain to conclude the public comment. After the individual's time for public comment has lapsed, the individual will be placed back on mute. Only one public comment per agenda item is allowed per attendee. 20 minutes will be allowed for the comment period for each agenda item. After 20 minutes, no further comment will be accepted. I want to remind all speakers to please stay on topic and talk and keep your comments to the allotted time or less. Today's meeting will be run according to the Open Meeting Act as required by law. We plan to end today by 3 p.m. Calling the roll to establish a quorum. I'd like to call the meeting to order. Ms. Moriarty, please call the roll.
Ms. Lubiano? Here. Dr. Bolot? Here. Mr. Brooks? Dr. Heelser?
Here.
Ms. Jones? Here. Dr. Mahmood?
Yes.
Mr. Rue?
Present.
Dr. Thorpe?
Present.
Dr. Sy? Here. Mr. Watkins?
Present.
Ms. Lawson? Dr. Hawkins?
Here. Thank you. A quorum is present. I'd like to remind the members again, we will be taking a roll call on all action items. Moving to agenda item 10, discussion and possible action on adoption of the controlled substance prescribing guidelines. Mr. Rajesh.
Thank you, Dr. Hawkins. Good morning, board members. So this agenda item is item number 10 on your agenda and in the notebooks. A detailed memo is listed in the packet there. Just want to highlight some important facts here. So this project of updating our prescribing guidelines was initiated by the board back in January 2021. And at that time, President Lawson appointed Dr. Hawkins and Mr. Brooks to the Prescribing Guidelines Task Force. And then the task force developed the initial draft and was disseminated to a lot of stakeholders at that time. And also we held a couple of interested parties meeting, one on July 14, 2022, the other on November 15, 2022. Those meetings were held for public input on the revised guidelines. And then moving on, there are some bullet points in the packet that kind of highlights the main highlights of the changes made in this updated guidelines. I just want to special mention to two ladies, Ms. Susan Cady and Ms. Letitia Robinson. These two ladies spend countless hours in researching, drafting, report writing, scheduling meetings, note-taking, and updating over the last 2 years. And this final product wouldn't be a reality without their hard work. So I just want to give them the kudos for their update. And at this time, I would recommend that the board, after review and discussion, adopt the task force's recommendation. And before we go into that phase, I would like Dr. Thorpe to summarize some of the updates in the guidelines.
Thank you, Mr. Borghese. You know, this is this project has been. We knew in the beginning it was going to be a difficult and complicated project. It has been way more than that, and so I want to just add my thanks to Ms. Cady and Ms. Robinson for their diligence and for the executive staff of the medical board in their persistence in trying to come up with a document that is a manageable document. I know there is a lot of concern about this document from the public sector and from the licensing sector, because this issue is a pervasive and an extremely complex and difficult issue. And we have come up with a product. I can't tell you that it's perfect. In fact, I won't tell you that it's perfect. I know that it's not perfect. There are issues still that need to be resolved. And as we've talked about before, this product is, as I look at it from a practicing physician, the number of requirements that we're asking for people to complete as they address chronic pain or persisting prescribing of pain medications, especially narcotics, and the complex interactions they have with benzodiazepines and other pain management techniques. It's a daunting list of things. If you go through and you try to say, well, this is how I would approach my patient, it's what we've laid out is a very complex process. I won't say that it's a process that I feel is completely ready for prime time. I mean, I think we're going to need to revisit this probably multiple times over the next year to get it right. I think morphine equivalent dosing, for instance, just to say one thing, morphine equivalent dosing has sort of put a label on and the ability to target doctors who are trying to do the right thing with chronic pain patients who still have intractable pain and aren't getting relief with the 90 morphine equivalent dose that we've sort of said was safe. And the truth is there's no safe, we found as we looked at this, there's no safe, I mean, it's not that I mean, the limit, the upper limit is different for different people because of their metabolism. So it's a complex process, and we don't want to say that just what we've tried to say here in this document, for instance, in the morphine equivalent dosing, is that we don't see 90 morphine equivalents as the upper end of the limit. However, there is legal reason to mention 90 morphine equivalents because that's a law that you have to at least discuss Narcan or naloxone with your patient if they're getting 90 morphine equivalents or more. So that is in the document, but the intent is still to soften that morphine equivalent limit. We are trying to create an environment in California where chronic intractable pain is not a curse, and where patients and doctors who try to deal with this very difficult problem are not cast aside on the highway of medicine because it's just too hard to deal with, and we just cast them aside as if they're not important. That is not our intent. And so there is, as you read through the document, you will find a number of the primary thing I would say is that documentation of your reason for why you want to prescribe pain medication, narcotic pain medication to this patient, the fact that you've really evaluated other alternatives and this is the best option, and that you have gone through a process of trying to identify what's the right dose to improve functionality. Those are the primary goals that we have set in this approach. And in the process of doing that, if we have gotten the language wrong, or if we haven't said things quite the way it needs to be said, we are not emotionally tied to this language here. We are willing to come back and change the language so it works better. We want this to be a working document. And last of all, I would say that this document itself is not going to change the environment. We have, back in the 70s, and I can speak from personal experience. I mean, I can tell you. I mean, I probably wrote. I can say on two hands how many triplicate prescriptions I wrote in a year period. It was very uncommon. Of course, codeine and hydrocodone didn't require that back at that time. But still, the times I wrote morphine or Dilaudid or Percocet, I just didn't write them. And when I moved in 2004 to be medical director of a rural health clinic, overnight, I was writing that many or more a day because of the challenge of the patient population that was so different than what I was used to taking care of. So I just want to say that we are very thankful for the public advocates. Many of them have given us very detailed information and requests. We have had very good subject matter experts who have given us very helpful advice. We've had the associations for pain and addiction who have given us input as well. And we don't want to just open up this back to the Wild West again, but at the same time, we want to provide an environment where pain treatment is back on the menu for the average primary care doctor and not something that they can't approach because their license is too much at risk. So with that, I would recommend for your discussion the task force guidelines for prescribing controlled substances for pain. And I would take just one if it's okay, Mr. Chair, I'd just like to take a point of privilege. I had asked Dr. Sean Mackey, who is chair of the Stanford University Pain Department, I'd asked him if he could speak during the period of time when we opened the mic to interested parties, and he was unable to. He's getting an award at Vanderbilt University, and he's being taken from one presentation to another, and just really couldn't fit it into his time schedule. So I would just like to read his written comments that I did ask him to speak. I did ask him to write something because he's a very thoughtful and articulate person. And so if you'll indulge me, I'm just going to read his comments. This is from entitled Oral Presentation to the Medical Board of California, Prescription Opioid Guidelines, May 1923, Sean Mackey, MD, PhD. Thank you very much. I'm honored to have the opportunity to make some public statements during this important event. By way of introduction, I am Sean Mackey, a professor and chief of the Stanford University Division of Pain Medicine. I am a physician scientist. I care for people suffering from chronic pain, many who have intractable pain. Also, for over 20 years, I've directed an NIH-funded group researching pain to develop safe and effective treatments, and I have no financial conflicts of interest. I served as senior advisor to the Medical Board of California in developing the revised guidelines for the prescribing controlled substances for pain. Our motivation for revising this document, last released in 2014, was to learn from the lessons of the past and make it better. In 2016, the CDC released their opioid guidelines. While well-intended, for a fraction of patients, the result was untreated and undertreated pain, serious withdrawal symptoms, worsening pain outcomes, psychological distress, overdose through use of illegal drugs, and suicide. We recognize the need to ensure patient access to safe and effective pain management treatment, and at the same time, the need to support physicians providing treatment for people with chronic pain. Consequently, we updated these guidelines to provide a framework for clinician use when using opioid for pain management. We included input from multiple stakeholders, including clinicians from numerous specialties, and most importantly, people living with pain. A common thread running through these guidelines is the need for individualized care based on the unique characteristics of each patient and the challenges they face. The guidelines do not replace a physician's clinical judgment and individualized patient-centered decision-making. The new guidelines are good for California clinicians and patients. What is clear is that the one-size-fits-all approach put forward by the CDC and others does not address our state's needs. What is also clear is that there is no perfect guideline. However, in talking with people with pain and physicians, I believe we addressed the most important issues. These new guidelines are an essential improvement and will positively impact the lives of those in pain and the physicians caring for them. In summary, these new guidelines are a big step forward in assessing and caring for people in pain. We have a lot still to do in areas that go well beyond these opioid guidelines. I look forward to working with you to making a broader impact. I appreciate the opportunity to work with the Medical Board of California and excited to see adoption of these guidelines. I would just make one last comment, and that's related to what needs to be done if these guidelines are adopted by the board today. There is a whole host of work that we need to do internally in the medical board in educating our investigative staff, investigating the Attorney General's office, in educating the Attorney General's office. There's a whole host of things that needs to be done with pharmacy and the Board of Pharmacy, because currently there's a huge problem with the supply of just the overall warehousing supply of these medications. Many of them are not available in any kind of quantity, or are not available at all now. And so, and there's work to do within the specialties. There's work to do at the health plans, because they have their own ideas of what needs to be done for chronic pain. But we are willing and committed to trying to work with them to try and help change the environment in California. And to that end, I submit these task force guidelines, or these task force recommendation for updating the guidelines for prescribing controlled substances for pain. Thank you, Mr. Chair.
Thank you again, Dr. Thorpe and Mr. Brooks, for your leadership in this area. Are there questions or comments from the members? Dr. Blatt?
Yes, thank you very much, Dr. Thorpe and Dr. Hawkins and all of those that worked on this very important document. And I echo what Dr. Thorpe said, and I would say this, that the challenge for the patient, for the prescribing physician is, as he said, we have health plans, we have pharmacy benefit management groups, we have pharmacists, and the entire system has been in upheaval since 2012, to be perfectly honest. When we were, as physicians, advised we weren't prescribing enough pain medication and we didn't understand it. And I would say that even the best of pain management experts, it is psychological, it's psychogenic pain, there's somatic pain, there's visceral pain, there's all types of categories. But the individual that's in pain is suffering. And so it's hard to be able to quantify. We've tried things such as a 0 to 10 scale and phases of, I'm kind of in pain to I'm in severe pain. And all of these things are very challenging. And as stated, when there's a drug supply shortage, when there are skepticism because I can't feel the patient's pain, all he or she can do is tell me that they're in pain. And I think the challenge is also the one area that I think really does need some explanation is that are we changing the functional status of our patient? And I think that when we see a patient come in and they may have whatever the MME is, are they participating in any kind of meaningful life? And can they? Are they spending most of their days on a couch and not moving, which then puts people with the hazards of immobility even further down the road. So this whole notion of pain crisscrossing through mental health issues is just such an enormous challenge. And I think that these are just what you said, Dr. Thorpe, these are guidelines. And we also need not only our all of the people you've mentioned, but also our healthcare consumer, because oftentimes people are frantic on a Friday afternoon trying to find pain medicines and saying, I can't get through the weekend without it. And these things are very, very difficult. And it's something that, as you stated, this is not going to be the end of this document. This is a living document, I hope, that we're going to be able to start to look at. And then finally, I would say the issue of co-prescribing medications that have an effect on the central nervous system. We worry about decreased respirations, and in hospital we measure CO2 now like we do pulse oxygenation to see how your oxygen levels are. But we have to think beyond what we're doing here with the opiates and the benzos and the Z drugs. And really, I think I'll say it this way, there's a lot of direct-to-consumer advertising that also impacts the way patients view pain and the medications, and here in the States, there seems to be this idea that there's a pill for everything. So getting back to the mental health issues, I think is going to be really crucial. So I would move to adopt what we have, and I really appreciate all the work that you put into this.
Thank you, Dr. Blatt. Additional members?
I second Dr. Blatt's motion.
Thank you. Mr. Watkins?
Yeah, thank you to Dr. Thorpe and Mr. Brooks and everyone else that was involved in this process. For me, as I'm listening and we've listened to previous experts, and this is, I see this as a challenge of our time as people become more medicated for all kinds of pain, because some of the pain is also a psychological pain that intersects with that physical pain. For me, the challenge is, how do we even begin to regulate this? Because we need so much flexibility around these prescriptions and these guidelines, and because it's so individualized that if I bring in a board expert right now and to make an assessment, they're going to make an assessment without having a full-scale understanding of the context of that. And that's why I was writing down Dr. Thorpe's suggestion of the documentation needs to really present the reasoning behind it.
Yep.
And that makes me more comfortable, because I think where we all lose these cases, which there's a lot of, and a lot of space to misinterpret, is that we don't see the patient, and when it comes to the enforcement part, there's too much missing. There's way too much missing, and the previous expert that gave the presentation pointed to that it was doctors' desire to help, but not having enough knowledge, perhaps. And, you know, he pointed out that there was only a small percentage that's really hurting people. So I understand this, and I love that it's a work in progress, a working document, because it means the environment can inform us over the next few years. So I'll support this. And thank you, Dr. Thorpe.
Thank you very much. Additional member comments?
Point of clarification. Once we move and second and adopt this document, I know that Dr. Thorpe said this is a living document. If there are changes to be made now, do we pull the document forward and vote for changes, or is this an internal thing that we start, you know, molding and shaping it into what it needs to be? So are we moving to adopt this document word for word and then subject to future amendments, or are we adopting this as this is our goal, and then internally, as Dr. Thorpe says, we're going to have to do a lot of work to shape it into its final form?
Yes, please.
Well, Mr. Chair, I think that's part of what the board is going to decide, Dr. Sai. I would see this document, well, what my vision would be, that the task force may need to meet again, or we may need to have another integrated party meeting in 6 months to see what's the impact of these guidelines, to see where we didn't quite get it right, and to edit it and bring it back for the board to revalidate, or to amend the document based on that input, or based on what the board feels is appropriate. I think it's going to take a couple of years of work seeing the document in its living form to see how it impacts the practice of pain management and just the practice of medicine in California. I don't think we could just say, well, this is the way it's going to be for the next 5 years, and like it or not, this is the way it is, because I just think it's too complicated for that.
Thank you for that. Additional members? Juliana.
Thank you, Dr. Thorpe. So once the guidelines are approved, I was curious, what does the timeline for rollout look like? Do we start outreach and make sure it gets out there to the right parties, or what does that look like?
That's a very good question. I think we haven't really actually talked about that. Part of it, we were so focused on trying to get a document we could present to you. But my personal thought is that, I think it would be helpful to have a webinar that we actually host that goes through the guidelines, that shows what we've done, but also be available for in-person meetings if we need to, for kind of promoting the guidelines and the change or not the change, but the board's willingness currently to try to promote an environment where treating pain is not automatically seen as wrong, as inappropriate. But it's going to take some work to try to get that change in attitude, because we've really chilled with the death certificate project and the CDC guidelines for 2016. we've really chilled the practicing, the average guy out there practicing medicine in a primary care practice. We've chilled their ability, their willingness to get engaged in this process again. They've had their hands, many of them have been burned, they've been disciplined by us, and they're really not interested in doing it again. And they're not willing to take that risk. And so unless we can, and it's going to take some work for us to get back to get them to be willing to, even with these guidelines, to be willing to get back involved again, I think.
Thank you for that. And I definitely think that's true. I mean, talking to some physicians and my own about that chilling effect, and I think some of it comes from fear and probably not enough knowledge of what the guidelines are and how we enforce them or, look at the situation. So, thank you.
Yeah. Again, great question. And Dr. Rue?
Oh, non-doctor. Just my initials, DR. But Dr. Thorpe, I really thank you for all your work and all the staff's work, because you talked about something that I wanted to present, where being a non-doctor, when it came to pain management or prescription of controlled substances, I saw all the horror stories, and that's covered in the news of overprescription, drug abuse from doctors, and anytime one of these cases came, I was super critical, very critical, till I started getting educated. And I started seeing the flip side of what you're talking about, of actual pain management, the need for pain management, which I was not aware of because that's often not highlighted. And because someone like myself was very critical of prescriptions by doctors, it made doctors not want to do it, because why go through that turmoil? So it really reassures me how much time and dedication that our board and our division, our department, is looking into pain management. And I really value the various professionals who've come before this board to talk about pain management, because it really has opened up another dimension that I never thought of. So it has been very helpful to me, and I really appreciate the thoughtfulness that went into this document. While not perfect, it's continually, we're moving forward.
Thank you, Mr. Rue. So as a physician in private practice who treats patients who have pain, because pain is so commonly, and being involved in medical societies, there will be extreme interest in this task force and our guideline changes. I think that we have a number of ways we can reach out. We have our webinar. The task force will probably meet again. We'll have communications with interested parties again. We'll have the newsletter. The board sends out important items to physicians via their email. So I think it'll be an opportunity to actually let folks know that we've done this. I think this will be one of the highlights of our meeting. Additional comments before going to the public?
Dr. Mahmood, I think, has a comment.
Dr. Mahmood?
Yes, sir. Can you hear me? Thank you so much. This is right now the most important issue we are facing at every end, on consumers' end, providers' end, and especially on board's end. There is so much scare, so much distress, so much anxiety, and people who are dealing with pain management patients, and there is so much issue on the providers that how to handle and manage that. Just for us to do a pain education here on the board or giving the guideline, I really think we need to go further and bring the pain management community together and do some seminar and have an active interaction with them, their challenges, their needs, and then come out to some guidelines so that people are not really hesitant. I have patients who drive sometimes 60 to 90 miles to find a pain doctor to get management, a treatment. And if some reason they miss it, they cannot get it, they're suffering. And everybody else who is their regular primary doctor or other doctor are so much scared to do anything because they have so many pain medications and narcotics and others that if they will add something else and something happen, they will lose license. So we really need to involve the community who is giving this service and getting their confidence, getting their input too, and then having a guideline would be a lot more helpful. I think that will also do a service to providers as well as the population and consumers in California, and also gives us that, when we look at cases, we have passed the real message that how much it is needed and where is it safe and where to draw the line, and that'll be very helpful. That's I wanted to express. Thank you.
Thank you very much. Tatsai.
The last comment, of course, I'd like to thank Dr. Thorpe and Mr. Brooks for spending all this time, and most importantly, the idea that the guidelines do not replace a physician's clinical judgment, because if we didn't expressly put that in there, it's italicized, it's bolded, this document become a standard of care document for people to waive in courts. And so we did not want to do that, and I thought it was excellent that you put that in, italicized, bolded, so that, this is not the recipe book. This is just a guideline to help you.
Thank you for that. Okay. So I have a motion and a second. Let's go to the public in the room. Additional comments from those in the room.
Hello, everyone. My name is Lucas Evanson with the California Medical Association. CMA would like to take this opportunity to thank the task force that worked on these revisions, along with all board staff who worked on updating these guidelines and for facilitating a successful process to ensure stakeholder feedback was incorporated into the new guidelines. We believe this, coupled with the CDC's updated guidelines, represent an important first step in addressing some of the barriers to care chronic pain patients are experiencing, and hope to continue to partner with the board to improve patient care in the state. Therefore, CMA agrees with the task force recommendation and requests that the board approve the updated guidelines for prescribing controlled substances for pain. Thank you.
Thank you. Additional persons in the room? Okay, WebEx, please.
The hand-raising feature in the Q&A window are open for anyone who wishes to make a comment. You can raise your hand or type anything in that Q&A window and we'll call upon you. And I see some people called in on phone-in only lines, so you can press *3 in order to toggle raising your hand on that call-in line. The first individual we have here is a call-in user. Oh, call-in user, I think you just toggled your hand back down. You had it, so go ahead and hit *3 and we'll come back around to you. Next in line here is Kate Nicholson. Kate Nicholson, you should be receiving that prompt now. Kate, you need to be at your computer in order to receive the, click the little prompt there to unmute your mic. Okay, we'll come back to Kate. Eric Andrews should be receiving that prompt on your end. Morning, Eric, your line's open. Eric, you there? I can see your line's open. Okay, Eric, we'll come back around to you. Rosie Arthur's daughter, you should be receiving that prompt on your end.
Hello?
Morning, Rosie.
Okay, thank you. I'd just like to start out by saying I think this launch should be delayed due to the fact that in the last month and just yesterday, there were Windows updates trying to fix some severe problems, so you have fewer people calling in because they can't access you. And I had difficulty getting in both yesterday and today, so that is a big problem. Now, thank you, Dr. Thorpe, for bringing up the metabolism issue. We know this is CYP 450, and this is something that has been known for at least 3 decades. It's a simple test, just like testing for blood type. it affects not only controlled substances and opioids, but medicines across the board and how they interact with each other. And that's probably the biggest problem that we have is because of litigation, fearing that they might accidentally prescribe a bad combination because they're ignorant of the testing opportunities, etc. Most of the pain doctors are not adequately trained in this aspect. But none of this is going to work unless you have buy-in by the large pain management groups that are intentionally ignoring any of the guidelines. The VA, and then what they do is when they don't want to do mandated care, they send somebody out to the outside who isn't going to get it at all. And the large HMOs. If they're not going to be online to honor these guidelines or the patient's rights to receive appropriate care, whatever that might be, as opposed to trying to mitigate potential damages, knowing that the sooner these people die, they're not going to be around to litigate anything. So if you can have a pain patient die from a heart attack or suicide, then you're not going to get sued for them not being appropriately managed with their pain medicine. That's the bottom line. But I think we need to have another meeting just because the access has been so difficult so that the people who are most affected, the patients and their caregivers, have a chance to go over these. And you really seriously need to get some buy-in by, as I said, the VA, the HMOs, and the large pain management people, because those groups, they're ignoring it. They are ignoring it. So thank you very much.
For your public comment. Kate Nicholson, it looks like your line's open now.
Yes, thank you. Good morning. My name is Kate Nicholson, and I am the Executive Director of the National Pain Advocacy Center. There is much I value in this update. Its emphasis on collaboration, patient-centered decision-making, individualized care and clinician discretion, its qualification of the use of MMEs, the clarification that deviations from the pain agreement alone may not indicate conversion, and that patients should not be dismissed based solely on UDT test result or finding of an opioid use disorder. The definition of tapering and of when a taper trial is considered successful, i.e. if treatment decisions are individual and based on the patient's response to the last dose, are all excellent. I have a few very minor suggestions. On page 20, it reads, quote, all patients, including legacy patients, deserve a slow, balanced, empathic, good faith taper trial. This language could be read as incentivizing tapering across all patients. Starting the sentence with the phrase where tapering is indicated would align the sentence with the rest of the document. Similarly, on page 15, where the guideline discusses failed tapers, OUD and buprenorphine transition, the following sentence appears. Quote, there is a fraction of patients who are likely benefiting from opioids, and a dosage reduction makes their pain worse, increasing their difficulty in weaning. Use of the term fraction here is potentially problematic, marginalizing, and even stigmatizing. In common parlance, fraction suggests that the number is tiny, the rare exception, the unicorn, creating a presumption that very few patients benefit from medication, or most who fail tapers likely have a use disorder. Replacing, quote, a fraction with some would significantly allay these concerns. There's excellent language in the section on legacy patients, acknowledging how long it can take for patients to find a provider. These suggestions should be cross-referenced to the general section on termination of care. If a patient is cut off medication in a termination of care situation, just providing the names of clinicians or a single bridge prescription may be insufficient to protect both patient safety and the provider from liability. Patients in an emergency situation could be considered abandoned even if the name of a new provider is offered and the 30-day time frame is met. Finally, given well-acknowledged disparities and inequities in pain treatment, adding a few sentences to the guideline to encourage providers to be mindful of not compounding existing disadvantages would be helpful. Paying for frequent drug tests when not covered by insurers, out-of-pocket costs for some alternative treatments, and even paying for both an opioid and naloxone prescription can be hardships for some patients. Presumably, this is why California law and the CDC counsel offering rather than demanding co-prescribing. Finally, where inquiry into abuse is addressed, language could be added to say that a history of abuse alone is not a reason to deny a particular treatment. Thank you.
Thank you for your public comment.
Mr. Chair, could we request, Ms. Nicholson, if you could put those comments in writing, that would be helpful for the task force. You probably made those comments before, but I appreciate, I mean, this is a little out of the way we normally do things, but if you could ask her to do that, I appreciate it.
Thank you.
Ms. Nicholson, your line's still open if you wanted to reply.
Yes, I'd be absolutely delighted to put them in writing and send them to you. Yes. Do you want them in writing in the Q&A, or do you want me to just send it in an email? That's probably easier.
If you could send them in an email, that would be great too.
Webmaster@mbc.ca.gov would probably be the best way. We can route it.
Okay.
Okay.
The board members that way. Thank you for your public comment. Next up here we have Lori Long. Lori, you should be receiving a prompt on your end. All right, Lori, it looks like your line's open.
Hi, can you hear me?
We can, please go ahead.
I'm Lori Long, and I am calling to encourage adoption of the new prescribing guidelines for controlled substances for pain. I am a person with chronic pain from a progressive and incurable autoimmune disease known as ankylosing spondylitis, which affects the spine. And in severe cases like mine, it causes spinal deformity. Since childhood, I have endured multiple surgeries, including a 13-level spinal reconstruction with rods, screws, cadaver bone, and all that good stuff, including fusion on multiple levels. I am considered permanently disabled, but my life had been truly enriched through pain management for over 25 years. During the time I had adequate pain management, I was able to participate in life in most of the ways really important to me and do things like take walks, work at least part-time, engage in meaningful activities and hobbies, including playing the piano, which brings me great joy. And I just happen to be an international medalist in piano for the United States. I was able to enjoy a social life and live well, even with my very painful condition. However, during the time surrounding the introduction of the CDC's 2016 guidelines, I was suddenly dismissed from care and abandoned from proper pain management. For years at a time, I was without proper pain supports and could not find a physician who was willing to manage my pain care. I did find many physicians who said that prior to these guidelines, they would have absolutely been happy and willing to treat me, and that long-term opioid therapy was the correct medical path for me. But no one could get past their fear of repercussions. I was even turned away from palliative care after being told that they no longer prescribed medications. One recurring theme also became clear. Doctors, granted under great duress from fear and anxiety of being wrongly penalized, were actually more willing to help me die comfortably than to help me live comfortably. This is something we must correct so that quality of life is valued at least as much as quality of death. My hope is that in the future, California will continue to move in the direction of respecting the doctor-patient relationship, have compassion for people who live with pain, and reverence for the doctors who treat us. I support the adoption of this new guideline, not because it's perfect, it's not, but because it's a step in the right direction with important updates, such as removing the arbitrary 90 MME guidelines to which we have been subjected and returns prescribing decisions to the clinician-patient relationship. I wish to express my appreciation to Dr. Sean Mackey, Senior Advisor, board members, especially Dr. Thorpe and Mr. Brooks for their leadership, and all the stakeholders who have come together to update this new guideline. And I urge its adoption. Thank you.
Thank you for your public comment. Up next is Amy Partridge. Amy, you should be receiving a prompt on your end to unmute. Morning, Amy. It looks like your line's open.
Very good. Hi, everyone. I am Amy Partridge. I've been an intractable pain patient for over 7 years now, and I'm just going to go off script a little bit and I'm going to cut out some of my personal pain story just to give you all an immense thank you. You have no idea how long some of us have been waiting to hear these words, that you want to put pain back on the menu. You're acknowledging the challenges that physicians have. It is multiple layers of interference from the federal level, the state level, professional organizations, insurers, DEA, et cetera. And it is just so good, not only to see this guideline, which is individualized and patient-centric, but also cuts out MME, and then hearing the discussion that you all are really, really trying to restore pain care has just been wonderful. So I'm going to echo a lot of what Kate had brought up, just as recommendations, if I may be so bold, in how to improve the guideline, which is already better than any guideline I've seen yet, and more individualized and patient-centric than any I've seen yet. So just a few recommendations. The first is to carry the patient-centered language from page 14 over to page 20 and remove the statements on failure and that patients deserve a taper. So on page 14, the tapering section has some of the most individualized recommendations, including taper trials are considered to be successful if treatment decisions are individual and based on the patient's response to the last dose change. However, on page 20, when we start talking about legacy pain patients, we seem to have lost that individualized language and have those who fail tapering can be considered for buprenorphine therapy or evaluated for substance use disorder. So we've not only changed the metric for successful taper, we've now called it a failure if a patient isn't able to taper, which it is not. So I just think that really individualized language on page 14 should be carried over to page 20. Recommendation number 2, again, echoing Kate, replace the word fraction. As you know, the term fraction is a little bit problematic as it implies a small percentage or an anomaly, and perhaps we could just replace that word with subset or some and scratch the term likely, because there are definitely patients for whom opioid therapy is helpful. Third recommendation, the language that recommends a provider-to-provider handoff, I think should be used throughout the document. You know, on page 20, the last sentence in the first bullet, maybe carry that to page 15 as well. And that sentence is, if unable to treat the patient, provide a direct provider-to-provider handoff, as it's the ideal scenario from a patient perspective. So I just want to thank everyone on the board, all the other specialties and disciplines, Senior Advisor Dr. Sean Mackey for this guideline. I hope that it is adopted and has a positive impact on both patient care and clinician comfort in treating pain. Thank you all.
Thank you for your public comment.
Sean, if you could just ask her to provide that same, if you would just provide those comments of her recommendations for edits in a email to you as well, that'd be great.
Absolutely, will do. Happy.
And again to webmaster@mbc.ca.gov. If you send it to me, it'll get there too, but webmaster is generally where we ask for the public comments come through. So thank you very much. Next up here, we have Tom Hayashi. Tom, you should be receiving that prompt on your end. Morning, Tom. Looks like your line's open.
Okay, thank you. Yes, I just, before I start my prepared comment, I just want to echo the how absolutely stunning it is to hear the positive comments by Dr. Thorpe and the others regarding the recognition of the pain as being something that's important to address. So I really am happy to hear that. Anyhow, thank you for the opportunity to speak. I have been an attendant and caregiver for my better half, Arlene, since 1980. Arlene has had pain since 1970 when she was stricken with a severe case of juvenile rheumatoid arthritis. The decade of the 70s led to multiple joint replacements and, near the end of the decade, a regimen that included opioid analgesics. This worked quite well for nearly 3 decades until a hip revision was required in 2007. Although the surgery was successful, things became more complicated with different opioid types and dosing. We had hopes that, with the passing years, pain treatment would advance along with more enlightened, compassionate views regarding the treatment of those with chronic pain in the community of disabled Americans. We had no idea of the nightmare that lay ahead. In Arlene's case, the current opioid hysteria arrived like a hurricane in October of 2018. Forced tapering, increased suffering, and doctor-patient relationships bending under intense pressure brought by crushing regulatory and law enforcement scrutiny became the new reality. America's record of undertreated pain was combining with our racist history and the iron law of prohibition into an authoritarian surveillance state seemingly bent on punishing people in pain, identified by the state as the supposed cause of the so-called opioid crisis. But with the medical board's new revision of prescribing guidelines, we are now seeing something different. This new document brings hope that those suffering from chronic intractable pain are now being listened to, that at long last, their concerns are being recognized. Your revision shows that concern and empathy for marginalized communities should lead, along with medical science, to policies and practice that heal and not harm. And finally, it lights a way to help envision a change in environment from the current callous disregard to one which sees kindness and compassion as not yet extinct from American society. Qualities I think we all agree are in short supply these days. All involved in crafting this document are to be commended for the concern and commitment, and we hope that this will move forward to adoption and implementation, allowing both doctors and patients to lead their best possible lives. So for your time, attention, and working for, as phrased in the Bible, the least of these, thank you.
Thank you for your public comment. Second here, we're going to go back to the call-in user on the 951 area code. Excuse me. You should be receiving a prompt on your end to press *6 to unmute.
I did, Sean. Can you hear me?
We can. Yeah, please go ahead, Monty.
Great. Excuse me. What an impressive set of comments, beginning with yours, Dr. Thorpe, and all of the public comments. Thank you for this opportunity to comment on this long-needed and very welcome update of the board's 2014 opioid prescribing guidelines. My name is Monty Goddard. I'm a licensed civil engineer in California. I advocate for my wife, who has suffered intractable pain since the late 1990s. Intractable pain, which for a decade and a half was safely and effectively treated with high-dose opioids. Coincident with the publishing of the 2016 CDC opioid prescribing guidelines and the medical board's death certificate project, that changed. She became, and now remains, collateral damage of our government's mistargeted and spectacularly failed war on the opioid epidemic. I actively participated at prior meetings in the board's updating of these draft guidelines as a patient advocate and interested party. This Dr. Thorpe led joint participation with the task force and interested parties has provided the much improved document presented to the full board today. Kudos to all involved. I'm very pleased with the diminished from last July's draft mention of the junk science MME metric. I have two suggested but simple to implement changes. First, add the words intractable pain to the heading of the section on page 18, which discusses intractable pain, cancer pain, and end-of-life pain. Although this short section has good words and mentions intractable pain 6 times, the omission of intractable pain in its heading will create undue confusion as it promotes the significance of cancer pain over intractable pain. This edit would then have to be made to the guidelines table of contents. Second, add palliative care to the list of defined terms on page 4. The last paragraph on page 3 of these guidelines exempts palliative care. The lack of a definition of palliative care begs confusion and related problems in the implementation of these guidelines. This is an easy fix. I emailed the board's Ms. Lopez an excellent palliative care definition that I got from the state of Maine. With these simple editorial changes made, I support and encourage the board's adoption of these updated guidelines. I eagerly anticipate their effective rollout, which will be no small undertaking. My sincere thanks to the board, and especially the amazing Dr. Thorpe, Mr. Brooks, Mr. Persifka, and the task force expert advisors. Thank you all.
Thank you for your public comment. I'm going to go Eric Andrus here. Eric should be receiving that prompt. If you're, I can see you connected by your phone now. You should still be able to unmute from your computer. There you go. Looks like the line's open.
Can you hear me?
We can.
Hello?
Let's go ahead.
Okay, good. First, thank you to those who so kindly sent me messages and emails of condolences yesterday. It was very sweet and heartening. Believe me, it's a hard time. In reference to what TJ said about what makes us comfortable, I need to take a slightly different tack to what most of the callers are bringing up. This report may be all well and good, but it's hard to listen to Dr. Thorpe's presentations when he solely consults experts who are members of the highly political and partial to Doctors California Medical Association. Along with Dr. Thorpe's strong CMA affiliations, Lee Snook and Sean Mackey are both CMA members, and their efforts have been called into question online previously in articles. When only 1/3 of California's doctors are members of the CMA, one would think that finding experts who reflect that low percentage to weigh in on important matters like this would be important. When it's all CMA members providing all of the information, we have to wonder if their information isn't just more CMA propaganda meant to benefit doctors over patients. I think when any of you make presentations by doctors, it should be made clear whether they are CMA members or not, since the CMA has a political agenda bent towards their members and have such a stronghold over this board. In the long run, you need non-CMA doctors weighing in on this important topic. You can roll your eyes when we call out the CMA, but it's becoming clear by the moment how much power they have over all of you. We need to hear from doctors, too, that don't have this political bent and agenda. It's concerning that more of you don't question things like this. This is an extremely important topic, and to have only CMA doctors weighing in on it is not fair, and it's not right. Thank you.
Thank you for your public comment. Next up here we have Kristen Ogden. Kristen, you should be receiving that prompt. There we go, Kristen. Looks like your line's open.
Appreciate the opportunity to comment today. I was thinking as the discussion began, I've been around and been listening to these meetings and speaking when I had a chance since early in 2021. And I know what a long and challenging road this has been for the task force, for Dr. Thorpe, Mr. Brooks, Mr. Persifka. I very much appreciate the level of effort that has been put into this project, and I fully appreciate its difficulty. I want to say that I agree across the board with the comments offered by Kate Nicholson, Amy Partridge, Lori Long, Tom Hayashi, and Monty Goddard. And I especially appreciated Dr. Thorpe's opening comments about what the board has gone through in the effort to make this real. I very much appreciate the focus on individualized care, the statement that the guideline does not replace physician judgment, the acknowledgement in the document that pain patients in some cases have very serious and complex illnesses, and that higher dose therapy may be the best for some people rather than a taper. I'm glad you see this as a living document that can be changed. I think that's very smart, and I appreciate what was said about perhaps having another interested parties meeting. I would welcome the opportunity to attend and be a part of that. I think it's critically essential, and I appreciate Dr. Thorpe commenting about the need for the board to reach out to others who have involvement in these complex issues. The pharmacy board, investigators, attorney general, insurance providers, PBMs, all of these. It's critical to look at the supply issue. I hear almost daily from patients who cannot get the prescription filled if they're lucky enough to get a prescription. We hope that these days will come to an end, but it's not going to be quick, not going to be easy. I appreciate very much the opportunity to have been a part of this, and I encourage that the board continue the dialogue, do treat it as a living document, come back for the changes, and perhaps consider trying to educate folks outside the medical community. I appreciated very much what Mr. Roos said, that I'd never thought about pain this way or opioid medications this way. This opened my eyes. I would like to see you guys maybe make webinars available to your elected officials in the state of California. There's a lot of other people whose eyes could perhaps better be opened. I thank you very much. As the wife of a person who is 73 years old and has had pain since he was 6 in 1956, I cannot overstate how significant this is to us. Thank you very much.
Thank you for your public comment. Next up here, we have Rhonda Favero. Rhonda, you should be receiving a prompt on your end. Morning, Rhonda. It looks like your line's open.
Can you hear me?
We can. Please go ahead.
Wonderful. Members of the board, Dr. Thorpe, Mr. Brooks, I appreciate this opportunity to give comment today. My name is Rhonda Favero. I'm a California citizen and have been deeply affected by past controlled substance policies, both personally and on behalf of my late husband, Larry, who just died of brain cancer and suffered greatly due to difficulties his doctors faced when managing his severe pain. I also live with a lifelong painful condition and have struggled with state and federal policies around controlled substance prescribing, which have caused me undue stress and suffering. However, I am hopeful and grateful to the board's updated guidelines for prescribing controlled substances for pain. I wish to lend my support and encourage adoption of this guideline. I know how long members of the California Medical Board, along with Senior Advisor Dr. Sean Mackey, and all the individual specialties work together to develop this updated guidance policy. I appreciate the efforts of the board to represent individual needs of California clinicians and patients. We need this updated guideline to encourage and allow California clinicians to develop individualized, patient-centered, medically appropriate treatment plans without fear of disciplinary actions, comparisons to other clinicians, or other past actions which have caused so much fear around prescribing of medically necessary controlled substances. I also have one request of the board. Please institute an educational program to make sure all clinicians are made aware of these new guidelines. To the medical board, its advisors, and all the disciplines who contributed to these guidelines, thank you for your diligent and thoughtful work on this manuscript, all of which will serve to better care for and protect California patients and clinicians. In closing, I urge approval of these updated guidelines for prescribing controlled substances in pain. Thank you so much.
Thank you for your public comment. Next up here, we're going to go to Andrea Anderson. Andrea, you should be receiving that prompt on your end.
I am Andrea Anderson, and I've worked in national and state pain advocacy for the last 8 years. I have cared for the medical needs of many California patients whose care was disrupted or eliminated during this time period. I also understand the tremendous upheaval and stresses that have haunted clinicians during this difficult time. Thus, I am calling in support of adoption of these new guidelines. The updated guidelines are a substantial step forward in the protection and care of both California physicians and patients. Thus, to all the members of the board and their support staff, the diligent work and leadership of Senior Advisor Dr. Sean Mackey and all the individual specialties who worked together to develop this updated policy, I want to say well done. It is such a positive move forward to see California protect and guide their physicians to develop individualized, patient-centered, medically appropriate treatment plans, and especially to do so without fear of disciplinary actions or other devastating events which so decimated the care of people with severe, permanent, and high-impact pain, but especially the clinicians who cared for them. I echo the concerns that others have raised surrounding the opioid tapering language, especially in the section regarding legacy patients. I won't repeat their comments here, but I do want to support the language that is used, which is stigmatizing, not evidence-based, and not internally consistent with other sections of this excellent guideline. Another point I'd like to raise, in the section regarding the treatment of pediatric pain on page 21, the manuscript reads, and I quote, "The same basic principles apply to children. A trial of opioids for short-term use has a place in the range of treatment options," close quote. And this is an excellent recommendation. However, a review of most other state and federal guidance documents uses the following language, which may allow physicians more discretion. Quote, "Opioid therapy should be offered with an intent to provide the shortest effective duration." And I make that suggestion as a possible substitution. Last, I also applaud the use of telehealth for pill counts, although I also want to urge the board to consider adding language that encourages clinicians to consider the privacy and safety of an individual patient's circumstances before arranging that option. It may not be a viable option for each patient. And one other option might be to allow a patient to visit a local pharmacy to satisfy that requirement. In closing, though, to the medical board, its advisors, all the disciplines, thank you for your diligent and thoughtful work on this manuscript. We are encouraged, heartened, and hopeful, and look forward to turning the tide to better care for and protect patients and clinicians in California. I urge approval of these updated guidelines. Thank you.
Sean, again, Ms. Anderson, if you could submit those comments regarding pediatric pain control and telehealth to the webmaster, I would appreciate that. That would be helpful.
Yes, sir. Happy to.
And the actual email address should be in the Q&A, visible to all there as well too, if just
Thank you.
copy down from there. Thank you for your public comment. Next up here we have Tamara Lynn Stewart. Tamara, you should be receiving that prompt.
Thank you.
Sorry, Tamara, your line's open now. Please go ahead.
Okay, thank you. First, I want to say thank you to the esteemed members of the medical board for this opportunity to share our thoughts and concerns today. My name is Tamara Stewart. I'm the founder and national policy director of the P3 Alliance, an organization working across the country seeking balanced policy around opioid prescribing. I'm here today to voice my strong support for the proposed guidelines for prescribing controlled substances. As a patient who's personally navigated the labyrinth of accessing necessary care, I firmly believe these guidelines are a pivotal step towards enhancing patient care and outcomes. These guidelines offer a beacon of hope as they provide more flexibility for physicians in treating patients who do not fall into those conventional guidelines. This means physicians can tailor their treatment plans to meet the unique needs of each patient. This will lead to better outcomes and improved quality of life. I also want to praise this board for recognizing that this document is not perfect, but that it is, and that they are committed to continuing to evolve this as a living, working document. This is needed to improve the care and to continue responding to the evolving landscape of pain management. This commitment to ongoing improvement demonstrates a dedication to patient welfare and ensures that the guidelines remain responsive to the needs and suggestions from the patients, practitioners, advocacy organizations most directly impacted. I'm here today as a witness to the devastating consequences of inadequate pain management. I've seen the sufferings of individuals who, driven by desperation for relief, not by addiction or abuse, have turned to illicit substances, risking overdose and further harm. I have mourned the loss of 2 personal friends and countless acquaintances, all of whom I was honored to know through our shared goal of advocating for compassionate pain treatment across the country. Tragically, each of them took their own lives when they could no longer find the care they needed. These experiences underscore the urgent need for comprehensive, compassionate, and accessible care. The guidelines recognize the complexity of pain management and the necessity of individualized care. They strike a balance between the need for controlling substance misuse and the equally important need to ensure patients have access. Moreover, the guidelines developed with input from a variety of stakeholders, which is in stark contrast to the CDC guidelines, which were created behind closed doors. I urge you to approve and adopt these guidelines and to go as far as necessary
30
to
seconds
inform
remaining.
and educate practitioners, demonstrating the board's commitment to reducing the chilling effect and providing support. By doing so, you're taking a significant step towards leading the country in a strong show of support for compassionate practitioners and effective pain management. This action will greatly improve the lives of countless individuals living with chronic pain while ensuring all patients have access to the care they need and deserve.
Please
Thank
conclude.
you for your time and consideration.
Thank you very much. This time, Dr. Hawkins, I'm not seeing any additional requests.
Thank you very much. May we have a restatement of the motion?
Sorry. I think the motion was to, for the board to approve the updated guidelines for prescribing controlled substances for pain.
Do we have a second?
Yeah. May I offer a suggestion too? Because there are some recommendations that may be non-substantive to the language, and so the board may want to consider delegating authority to the task force to make non-substantive changes to the language as we work through just the final document before posting. So that's a suggestion that the board may want to consider. You don't have to, but it may be worthwhile.
Dr. Tsai?
I'll offer the friendly amendment that we move to approve the proposal with the non-substantive grammatical changes as necessary by the staff.
And the task force, you're delegating.
And the task force, yes.
The authority to the task force to make the determination that the changes, suggested changes are non-substantive and that they can incorporate them into the document as deemed appropriate by the task force.
Correct.
Okay.
That's
so
the friendly amendment.
And is that acceptable to the seconder?
I accept the amendment.
All right, do you call the roll?
Ms. Lubiano?
Yes.
Dr. Bolat? Dr. Hilzer?
Yes.
Ms. Jung?
Yes.
Dr. Mahmood?
Yes.
Mr. Rue?
Yes.
Dr. Thorpe?
Yes.
Dr. Tsai?
Yes.
Mr. Watkins?
Aye.
And Dr. Hawkins?
Yes. The motion carries. Briefly again, Dr. Thorpe's invitation of persons to send suggestions is appreciated. Again, we want to thank Dr. Thorpe's, Mr. Brooks, and subject matter experts, and the public for assisting the board with updating these guidelines. I want to give a special thanks to Susan Cady, who coordinated this project to update the guidelines. I do want to amplify the involvement of consumer advocates who push this necessary endeavor. Again, as stated previously, we want this to be a living document that will recognize changes in the real world. Goals include public protection, public safety, and improvement in quality of life. Moving on to agenda item 11, discussion on the initial report of the enforcement monitor, Mr. Lombardi. Welcome.
Good morning.
Right.
Good morning, members.
Great, we hear you.
I am Les Lombardo from an Alexa and RPM.
My name is Randall Summer, also with Alexa and RPM.
We were engaged to perform this, as the enforcement monitor, to perform this review relative to the enforcement protocols, practices, et cetera. Just a couple of upfront comments, and then we're going to jump into what we've agendized. Randy and I have been practicing CPAs for decades. And in these types of review engagements, assessment engagements, we typically hear, uh-oh, the auditors are here. And all the auditors ever do are write critical negative reports, okay? Well, our approach in doing these types of engagements, as witnessed by this report, we always, in doing the evaluation, we look for the strengths and the weaknesses as we proceed with the engagement, with the review. And our report is reflective of that, right? You'll see a number of items that are called out, and this is the initial report, right? We're currently working, we're doing additional work, follow-up work relative to this report, follow-up report, and then we're doing additional work. And you'll see we've called out both strengths and weaknesses, and particularly the 4 findings in this report that we've identified. And so that has always been our approach to these kinds of engagements. The other thing I want to say is the quality of engagement is directly correlates to the staff that we work with. And the medical board enforcement staff, together with HQIU, the sworn investigators, and that entire unit, and together with Ms. Castro at the Attorney General's office, they have worked with us tirelessly, and they've responded to our requests for information, our requests for interviews, and so we just want to acknowledge that we are very satisfied with the participation that we've received from all of the staff that's been involved in this engagement to this date. Okay? So as we go through the process, complaint intake, right? Complaint triage, CCU, all the protocols, you'll notice that we've identified a number of business process improvements that have been implemented over the last 4 or 5 years, and those were all self-initiated by staff as they continually look at how can we improve the process. They so act to the extent that staff can act without having to have statutory change, right? Same is true with the investigative staff at HQIU, right? They've implemented a number of business process improvements, which we've specifically called out in this report. For example, standing up the EPU unit, right? Bringing that kind of protocol, we find it to be very constructive for program improvement and performance. Having a centralized group, ensuring that a quality of standard is met relative to investigative reports, and then coordinating from that centralized group the necessary medical experts that are needed relative to that particular type of case and the unique circumstances of that case, we believe is a definite improvement over what previously existed. Okay? Finally, the other significant quality improvement of the board is, as you're well aware, 36 boards, bureaus within consumer affairs, and back in late 2013, they migrated to a dedicated platform known as Breeze to serve boards, bureaus, and commissions. About half of the board, about 18 of the boards, bureaus, and commissions are on the Breeze system, of which the medical board is one. That is, as we define it, that is their system of record. It captures all the data necessary to adjudicate the program, both licensing as well as enforcement. There have been some challenges with that because it's a COT system that has to accommodate all the departments on that system, and it's difficult to customize a system unique to any given board or bureau. But what DCA also did was, I believe it was about 2018, they adopted IBM's Cognos analytic tool, which sits on top of data. It's a very powerful analytic tool for data gathering, data analytics, slicing and dicing data, and reporting on that data. And the benefit of the medical board relative to a number of other DCA boards is the medical board has a dedicated IT staff, ISB. And they have a couple of individuals that we worked very closely with that have embraced that Cognos analytic tool, what DCA and what MBC refers to as Qbert. But as you read our report, especially in section 4, we call out the benefit of having this uniquely administered by MBC staff and the ability over the last 4 years to really improve data capture, data analysis, and data reporting, not only in the public reporting that you're required to do, but probably more importantly, as we call out in the report, all the management reporting, the unique reports that have been built for MBC management and for HIQU investigations, tailoring those reports to more efficiently and effectively manage enforcement. Any questions so far? Okay.
Please continue.
Right. Then we get into the 4 findings. So there are 4 findings as of this report, right, as we lay out. And the first finding is what we're calling is the lack of an investigator workforce, the staffing resulting in case delays, disruptions, and inconsistent investigations. We looked at an 8-year period, as our report indicates, as you see all the metrics that we put together. And it's been very difficult to maintain a viable sworn investigator workforce. Consistent turnover, consistent. It takes 3 to 5, we interviewed well over 20 investigative staff, from the chief, commanders, supervisors, investigators themselves, and over a half a dozen individuals who left and continue in their investigative capacity but are working elsewhere. It's been very challenging. And when you look, and so we also look back over the last 20 years, and those challenges have been consisted over 20 years in maintaining this viable investigative work staff. When you look at enforcement, and when you look at all 3 of the first 3 findings are all tied together, right? Relative to actionable cases, what we're deeming as an actionable case, right? Investigation and prosecution are inextricably linked. You can't do one without the other. Prosecutors cannot go forward without viable, substantial, significant, completed investigatory matter, what we're calling the body of knowledge. And rightfully so, investigators in conducting the course of an investigation, which is multifaceted, and the dynamics of any given investigation change during the course of that investigation. More often than not having prosecutorial assistance, collaboration in that process impedes the ability to effectively and efficiently put together a case. Another time in my life, right, I was a forensic auditor with a specialty in fraud examination, so a certified fraud examiner along with my CPA, et cetera. And a number of those cases resulted in civil action as well as criminal action. I participated as, quote, the investigator. We were the auditor doing the audit, and the audit was the basis for a criminal action. And we worked with local district attorneys, we worked with the state attorney general's office, and we also worked with federal prosecutors. And in conducting this over a period of years, in order to be successful in achieving the outcome that we wanted to achieve, the audit and the prosecutorial team worked collaboratively, concurrently during the process. Otherwise, it's hard to put together a case, the needed analysis in the right format, the right consistency, the right context, if we don't know what the target is. And that's why collaboration is key. What we're seeing is, in the metrics that we've provided in our report, the metrics show that the length of time of investigation, the length of time of prosecution, over the last three years, the number of submitted cases to the Attorney General's office, to HQE, the number of rejections and/or returns has significantly increased since the termination of VE. We looked extensively at all the components of VE, how it came about in 2006. We spent a lot of time with the 2004 monitor's report. We looked at the substantive changes that occurred in 2006, right? The subsequent evaluation of the first 3 years of the VE rollout in 2010, the problems associated with that, and then the continued effort of VE from 2010 through 2017, where it culminated in the great debate of legislative hearings throughout 2017, whether or not to continue with VE or to terminate VE, and then ultimately vertical enforcement terminating at the end of 2018. And when you look at the metrics that have occurred since 2018 and the lack of a collaborative protocol between investigations and prosecutions, the numbers have significantly increased, indicating a problem. Prior to 2018, as our report indicates, rejections 2 or 3%, return for supplemental investigation 3 or 4%. In the last 2 years, those same numbers, 20% rejection of cases, referred cases over, 15% of those cases returned for supplemental investigation, a second investigation, a third investigation. We even found a fourth investigation necessary to put together the body of evidence needed for the Attorney General's staff to go forward with an actionable item. Okay? Time, effort is spent in doing all that. And then especially, you're up against the statute of limitations hurdle that a number of MBC's peers in other states are not faced with. You know, so these challenges are magnified when we don't have this collaborative effort that is necessary, but we strongly believe, based on business models. When you look at business models that are very similar in this nature, right? Different disciplines working through a structured, sequenced process to a desired end, okay? Information technology is a classic example that ties directly to this. If those different disciplines at various phases of the project are not working collaboratively together, you get an outcome that in many instances is disastrous. When you flip the switch on the technology platform, it doesn't work. However, when you look at highly successful projects, when you flip the switch the first time, the system works, right? And when you look at the underlying factors that contribute to that, one of the key factors is the collaboration of different disciplines working together during the course of that project. So what we have here, 10,000 complaints come in the door every year. They are, there's a rigorous process of evaluation of those complaints, right? A determination is made somewhere between 10 and 15% of those cases are what we call thrown over the fence to formal investigation. That process, a series of protocols, processes, and procedures relative to each different case type, case category is executed. The outcome of that, if in fact deemed actionable, is then handed off to the Attorney General for seeking the appropriate administrative action relative to the case before them. Criminal actions are referred, and there's a small number, but every year, criminal actions are referred to the local county district attorney. When you look back over the history of what I'm talking about, so from 1996 to about 2004, 2005, medical enforcement had what was known as DITO, DAG and district office. There was a collaboration of the investigative units within the localized field offices together with district attorney DAG liaisons, and they worked together in building actionable cases. 2006, that was replaced by vertical enforcement, and you've all read the history of vertical enforcement, the positive benefits and the negative benefits, and ultimately it was decided to terminate vertical enforcement. Now we're operating in what's known as the handoff model. So initial evaluation, medical consultants, over to investigation, investigators building the body of evidence. HQIU has their complement of medical consultants. When it's deemed to reach that threshold of this is an actionable case, the appropriate medical expert with the appropriate discipline is chosen to do that evaluation. If it in fact is deemed to be significant or extreme departures, it's then referred over to the Attorney General. The Attorney General, Ms. Castro and her teams, they're seeing the case for the first time when that case is referred over. So that now they're going through their distillation process, evaluating what has been presented to them, and they're seeing it for the first time. And what we're witnessing by the metrics is 20% of those cases are rejected, and 15% of those cases are returned for further what's known as supplemental investigation. We don't view that as a viable business process in conducting these evaluations that build the proper components to sustain a medical enforcement action. We've laid all this out in our report. We're doing further analysis on what we've described in our initial report, and we're going to report back with more detail in our final report. So, maintaining a viable investigative workforce, without an investigation, a properly constructed investigation, you can't even get to referring a case over for action. Without this collaborative effort, what we put in the report, contemporaneous collaboration at key points in the process, and depending upon the type of case, the care issues, the standard of care issues in a given case, because obviously there are different types of standard of care issues, right? That collaboration will vary depending upon the type of case that is before the enforcement team. And so what we're advocating for is collaboration has to be restored, and the different types of protocols of collaboration at key milestones during the course of that collaboration will then be identified and established. In looking at this, what we identified, there's a strategic component to this, and there's a tactical component. Whether it's medical enforcement, whether it's IT, whether it's engineering, whether it's construction, all these analogous business models. The strategic, what are we going to do? Given what we're faced with, given what's before us, this particular case, what are we going to do relative to this case? The strategic. Then the tactical, how are we going to do it? How are we going to execute? While the strategy may in fact change during the execution of a case, typically the tactical component of that, the how, that dynamic changes as you go through the process, especially relative to these very complicated cases. As evidence is obtained, things change. Ultimately, when you look at the outcome of this, cases are handed to the AG, and it's the AG with their seasoned experience relative to legal standards, legal protocols. Can I go forward with this action successfully? Well, not having, in our opinion, not having that collaboration during the course of investigation impedes the ability to get effective and efficient outcomes the first time through. Okay? Enough said on that. The other critical component of this, and virtually throughout the last 6 months of conducting this review, everyone agrees, and it's in our report, for a quality of care actionable case to proceed, the medical expert is the critical component. The case is made or broken on the expert's opining, the review and opining. And in our third finding, you'll see that there is not a sufficient medical expert pool necessary to adjudicate these cases, and that's been an ongoing problem for the board. We're actually, as part of our follow-up work right now, we're actually interviewing physicians, both those that currently participate or have participated in the expert program or have been contacted previously by EPU via the off-list process, seeking medical experts to come in and join the program, performing this needed evaluation for the case before them, and these physicians have not accepted that. So we're actually conducting interviews with physicians, with your peers, trying to get a much better understanding of all of the issues relative to recruitment and retention, and what would it take to improve recruitment and retention so that we can offer in our final report more viable recommendations to overcome this really a systemic continuing problem. Without the expert review, the case cannot go forward. Okay? And then finally, our fourth finding, which some have said really should be our first finding, the lack of funding to properly maintain program operations. And over the 20-year period, I mean, we were looking at this 6-year period, but we looked back at various times. So at various times, the board has had adequate funding, and then at various times, it has not. The 2004 enforcement monitor had a lot to say about creating the necessary funding to administer the program. And there was a slight augmentation of funding, and then for years it did not exist. I think since 1996, as our report indicates, there's been 3 augmentations of funding, right? And over the last 3 years, 4 years, and projected over, I think, through 25, 26, you cannot operate such a critical, important, vital program by deficit funding. Currently a $10 million loan to be replaced by a $12 million loan to be replaced by a $27 million loan, okay? It doesn't work. Randy and I are CPAs, okay? In CPA terminology, right, if we were doing a financial statement audit and opining on the current financial position of the medical board, which we're not, we're not, right? But we would have what's known as a going concern problem. Given the current structure, this entity known as the medical board cannot viably sustain itself. Going concern, I mean, think back to 2000 and Enron, okay, where their retained auditor gave Enron a clean opinion for 2 years when in fact Enron was completely upside down, and when Enron imploded, like it did, so did the 82-year-old audit firm that issued those clean opinions. But we're not issuing a financial statement audit, we're issuing a programmatic review, and so we would not be issuing, quote, a going concern problem. But we want to stress just how critical that is. The two components, the two essential components of the medical board, the licensing component, some 177,000 currently licensed physicians, okay, and medical enforcement, about a 25, 75, 30, 70 split, okay? When push comes to shove, like we put in our report, would you stop licensing doctors, either initially licensing or relicensing doctors, or would you curtail enforcement activity when funds are short? Our belief is you would continue, you would sustain the licensing operation. You would have to license and relicense doctors, and the shortage of dollars would curtail enforcement activity.
Thank you very much. I don't want to stop you from speaking, but thank you very much. When will your final report be delivered?
Currently, it's, we're targeting the end of July.
End of July. And not to get ahead of yourself, are you expecting substantive changes between the 4 areas you presented so far?
Not substantive, but more detailed information to a certain degree, and then enhanced recommendations.
Thank you very much. Do the members have comments or questions? Dr. Hauser, Watkins, Dr. Thorpe.
Thank you, Mr. Lamario. I learned a great deal from your report and appreciate your very thoughtful discussion of your findings. It seems to me that many of the findings that you called out would need to be addressed by action by the legislature, and I'm curious if you've had any interaction with them since releasing your initial report.
We have not interacted with the legislature. We don't believe that is part of our protocol to do that. There is a legislative process. I mean, I would refer to your legislative consultant. I mean, if called upon by the legislature, we would certainly answer. But our understanding under SB 806, our interaction with the legislature is to produce the what is known as the initial report and the final report and direct that to the legislature. And then if the legislature wants to entertain that and have subsequent discussions with us, that's our understanding of the protocol.
Thank you.
Okay.
I have a few observations, and I can honestly say I've been waiting for this for a long time because I've spent probably the most hours on these same issues. And what was encouraging, I was ready to dismiss everything that you said, just out of bias. And I must say, once I read the report, I was encouraged. And this is what I mean. You found the core issues that ultimately present itself in numbers that are presented to this board, in the outcomes that we produce. And you so rightly point out that this investigation is linked to the prosecution. And when we have the number of 20% being rejected and 15% being referred back, it points to a bigger relationship problem that exists at the investigator level, say HUIU, and the AG's office. And that lack of communication, I think it's also cultural. I've worked in cross-functional teams where legal is involved, and legal runs the show in general, right? So you have the investigators, they have a set of outcomes and their protocols that are in place. I would not be so bold as to say that they don't know what they're doing, because 9 out of 10 investigators know the law and the parameters in which they operate. So I'm familiar. I can say, let's assume that they know what they do. It gets passed on to, so they have to meet the standard. They have to build a case that is to the evidentiary standard and above. So let's assume they're doing that. They get to the Attorney General's office, and the Attorney General office says, you're not meeting that burden, so 20% will just get outright rejected, and another 15% get referred. So here's the issue. At what point does the Attorney General's office get involved and become part of the team? Because to get these numbers that are ultimately revealed, even at this board level, and the numbers are pretty dramatic statistically, there's an unequal relationship. That's not a partnership. That is a dictatorship. And the dictatorship comes because somebody knows the law and they have the final say. And you only have a final say if there's not a solid process in place, like you say, a strategic which maps out the whole vision, and then the tactical to say at every level, everybody's participating. And I'm not sure if you're going to make any enhanced recommendations or suggestions how to address those issues, because I do believe that is, it may have become cultural at the board, because we have a 99% agreement rate with the Attorney General's office's stipulations. 99%. That's by far the most unequal relationship. And that's because we are mostly powerless when they present us facts. We are powerless because the legal doom and gloom that is presented to us is too much to face for normal folks, right? And so that was my first point, is that relationship. And you pointed out, let me just get my notes here. You pointed out also as to the financial stuff that, our last fee increase was in 2005. And we had to give up something in order to get that fee increase, which was cost recovery, which is a tool that is used during negotiations. And when that tool was taken away, it made room for now, you've taken a tool away from me, a bargaining tool, and now I have to give up something during when you go into the actual, outcomes. You have to give something. And I believe, and I can say that, not to bias your process, you'll just find it or not find it, is that we then went to the guidelines and say, okay, we can deviate on one specific one, the probation, and we can make a deal based on that. But that also erodes the confidence that the public has in us. And so, like I said, I respect the work you've done. It's pretty spot on, because I found very similar things, but working it backwards.
Dr. Thorpe? Thank you, Mr. Chair. I also appreciate a great deal the work that you've done, and I think it lays out in a kind of relentless pattern the ways that we have that we're struggling as an entity. Not just it's clearly our real issue right now is we're underfunded, and we are not going to be able to continue without some significant change in trajectory on our funding. We are hopeful, again, we're dependent on the legislature to enact this fee increase that we've requested, and there are other items that we've requested. Hopefully these will be enacted, but currently those are, they're in the process. If those things don't happen, we are not a viable concern.
Exactly.
And that's, I think, I'm hoping that information is being relayed to our legislative folks that are in control of that in the legislature, because that is clearly the issue. That may be out of our control. We've already made the recommendation, we've made the request, and that is what it is. But I think I would like to go back to this issue of collaboration. And I assume that there will be some more specific recommendations for the collaboration between investigation and prosecution as we go forward, as the final report comes back.
We put a number of, yes, there will. And back to the financial issue, seeking these periodic augmentations of budget, if history is any judge, has been very challenging, right? So that's why we specifically referenced some type of CPI, some type of barometer in there at specific periods of time with the with the chosen appropriate metric to automatically adjust fee increases upward, right? It's the CPI index. It's right.
Right.
So you don't. So there is some guarantee that with inflation and increasing costs, that the revenue stream, the income stream, will be adjusted upward. Maybe not to the extent that it needs to be, but there's some built-in guarantee that would occur.
Okay. Thank you.
Thank you. Any others? Okay. Any comments from those in the room? WebEx.
The hand raising feature in the Q&A window open. Anyone wishing to make a public comment? Go ahead and queue up now. Anyone on a call-in only line, you can press *3 in order to toggle raising your hand that way if you're not connected to a computer. First up here, we have Marion Hollingsworth. Marion, you should be receiving that request. Marion, I hear you. Please
Okay,
go ahead.
thank you. Good morning. Still morning. I'm Marion Hollingsworth, patient safety advocate. After reading this enforcement report and hearing what Mr. Lombardo had to say, I have to shake my head. How could a state agency regulating doctors in a big state like California be this embarrassing? This report found the board to be understaffed, underfunded, unorganized, with only about half of its experts qualified to review a case. Better funding solves some of these issues, but many have been around not just for years, but for decades. So many of Mr. Lombardo's findings mirror what we advocates have told this board, such as ignoring guidelines when disciplining poor experts and the AG failing in its mission. We've been telling you about cases that are immediately tossed. I hope you all take this report seriously and endeavor to rectify the issues that have brought this board considerable criticism over the years. Don't just file this report away and check it off your list as an assignment from the last Sunset Review. The reputation of the board and even your own reputations are on the line. Not only that, but this failure puts the lives of thousands of Californians on the line every year when you don't do your job to protect consumers. If the CMA can pressure legislators to do their bidding with licensing fees and other issues, so can you. You board members can pick up the phone and get attention much more readily than we advocates can from legislators. The future of the board and patient safety in California is riding on all of you. Please find a way to fix your problems and don't rely on the CMA to advise you. Thank you.
Thank you for your public comment. Still checking here, but at this time, Dr. Hawkins, I'm not seeing any additional requests.
Oh, really? Okay, thank you. Well, thank you both. We appreciate your thorough evaluation and preliminary potential recommendations that really accurately documents where we are. Amplifies the board's strengths and weaknesses as it impacts on really one of the majority areas that we are responsible for in our mission, that of enforcement. So members of the board got together last night socially, went home, worked on some things, looked at what was going on today, called my wife, and had trouble sleeping. And had trouble sleeping because I was thinking about the dedicated board, I was thinking about consumer advocates, and I was thinking about the legislature, who we suffer. We are in their hands. We recently went before the board in Sunset, and we told them what we need and why. And you've amplified this. You've given us additional ammunition. So I hope that the legislators and their staff hear and see where we are. We're at a critical point, and I hope that they recognize that we have a responsibility. They have a responsibility, and we have a responsibility to the citizens of California. They need to give us what we need to do our job. Thank you.
I just have a final question. Do you have a legal expert as part of your team?
We We do not.
I think you may need that in the next part of this, for this, because it becomes extremely legal. And I'm just afraid, honestly, I mean, I'm just afraid you're gonna get kind of squeezed out, because sometimes that is what happens on this board. We get squeezed out with legal fears. And I just desire that perhaps a legal expert could help you navigate that space more comfortably.
Something to think about, for sure.
We will take that under consideration.
Thank you again very much. We appreciate you.
Thank you.
Moving into agenda item 12, discussion on postgraduate training license and physician surgeon license application process. Ms. O'Connor.
Good morning, board members.
Good morning.
Thank you for this opportunity to provide an overview of the licensing application process. My presentation will focus on application processing, communications with applicants, and possible outcomes for licensing applications. Next slide, please. All PTL and physicians and surgeons license applications may be submitted through the BREEZE system. PTL and transition applications must be submitted through BREEZE, and as of June 1st this year, the physicians and surgeons application will also be required to be submitted through BREEZE. An applicant may submit all required documents through BREEZE by attaching them when completing the online application. Documents required from third-party entities may not be submitted through BREEZE. All required fees may be paid online as well. Except for the application to transition from a PTL to a physicians and surgeons license, all required fees must be paid before the board will process the application. Next slide, please. If an applicant is requesting their application be expedited, then they must provide all required documents and meet the expedite criteria established in statute. The board will not expedite the application until it has determined that the applicant meets the expedite criteria. When an application is expedited, it is moved to the top of the pile during the review process. The applicant must still meet all licensing requirements and submit all required documents to be issued a license. Next slide, please. All documents submitted by medical schools and postgraduate training programs may not be submitted by the applicant. They must be either mailed to the board or submitted through the board's Docs portal. If submitted through Docs, they do not require a program seal or notarization. The board encourages medical schools and training programs to submit through Docs to cut down on time processing mail and to be able to confirm the board's receipt of the document. In our effort to transition to a paperless application process, the board will soon be requiring all documents from medical schools and postgraduate training programs to be submitted through Docs. Next slide, please. A paper application must first be cashiered. An online application is considered received as long as the required fees are paid. A transition application does not have an application fee, so the board may process these without a fee. If an application is received without the required fees, whether by mail or online, the applicant receives a letter requesting payment of fees within 30 days. If no payment is received, the application is closed. Once the required fees are received, the application file is set up and assigned to a reviewer. Next slide, please. Applications are reviewed in date order received. If an applicant requests expedite, then these applications are first reviewed to determine whether they meet the expedite requirements. They will not be expedited if they do not meet the statutory requirements. Once an application is reviewed, the applicant will be emailed a deficiency letter outlining all required documents. When documents are received to remediate deficiencies, they are reviewed in date order received unless they are an expedite application. When staff review documents, they may determine the document is incomplete or may need additional information. Receipt of all required documents does not mean the application is complete. Based on the information provided through the application process from the applicant and third parties, additional review may be required. The applicant will be notified by email if new deficiencies are identified, but not when a deficiency is remediated or a document accepted, as the list of deficiencies can be viewed by the applicant in Breeze at any time, and they will be updated when a deficiency is remediated. If there is no action taken to remediate a deficiency or communicate with the board for 1 year, then the application is closed. The applicant is notified when their application is closed. Next slide, please. Whether an application is submitted by mail or through Breeze, an applicant can register in Breeze and check the status of their application. Breeze will show the list of deficiencies emailed to the applicant. When a deficiency is remediated, it will be removed from the list in Breeze. Any new deficiencies will be communicated to the applicant by email, so it is very important for the applicant to maintain a current email address with the board. Applicants often put an email address on their application that is not their personal email address and are unaware when the board communicates deficiencies or updates to them. Due to the high volume of applications, staff are not able to respond to requests for application status updates or requests to confirm the receipt of documents. Documents submitted electronically are automatically received by the board. To confirm receipt of a mailed document, the sender may use a mail tracking service. Next slide, please. When all deficiencies have been remediated, the application moves forward for a final quality assurance review. If an issue is identified during the final review, it must be resolved before the license can be issued. If no issues are identified, then the application moves forward for license issuance. Once the license is issued, the licensee will receive an email within 1 to 2 weeks of issuance. Once issued, the license will immediately display in the online license lookup. Next slide, please. The board is mandated to evaluate each application to determine compliance with the law and whether the applicant is safe to practice with a full and unrestricted license. This process can be lengthy and require a lot of information, especially if there are unusual circumstances, such as prior criminal or disciplinary history, issues identified during postgraduate training, or any other issues that may require additional review. This is why the board recommends applicants apply at least 6 months in advance when possible. Next slide, please. If there are unusual circumstances, the application will first go through a preliminary review by a licensing manager to determine if a full and unrestricted license may be issued, if additional information is needed, or if the application must proceed to a higher level review based on the circumstances. If additional review is needed, then the board's specialized analyst will review the entire application and determine if a full and unrestricted license may be issued, or if the application requires review by the board's senior staff. During the preliminary review and the review by the senior staff analyst, additional documentation may be requested of the applicant. Next slide, please. If the application requires review by senior staff, then the analyst collects and prepares all information needed. Senior staff consists of the senior staff analyst, licensing managers, the licensing chief, the director, the deputy director, legal counsel, and a deputy attorney general. There are many possible outcomes of the review by senior staff, including an additional assessment or evaluation, referral to a medical expert, offering the applicant a probationary license, issuance of a full and unrestricted license, denial of the application, or that additional information is needed before a final decision can be made. Next slide, please. When an applicant is offered a stipulation for a probationary license, they may either accept or reject the offer. If they reject the offer, the application is automatically denied and the applicant has the option to appeal the denial. If appealed, the application is referred to the Office of Attorney General and is set for hearing with the Office of Administrative Law. If the applicant accepts the offer, the stipulation is sent to the members of one of two board panels for vote. Panel members may either accept or reject the stipulation or hold for discussion. If panel members hold for discussion, then the stipulation is discussed by the panel at the next scheduled full board meeting. At the board meeting, the panel may either adopt the stipulation, adopt with modifications, or reject the stipulation. Next slide, please. Here are some licensing statistics for fiscal year 2021-2022. We received 10,834 physician and surgeon and PTL applications and issued 9,843 licenses. As you can see in the table, a very small number of total applications received are issued a probationary license or denied. Only 0.1% of the total applications received are issued a probationary license or denied. In all of the applications that resulted in denial or probationary license, the board determined that the applicant was not safe to practice with a full and unrestricted license. The board requires a lot of information to make these decisions to ensure consumer safety, and even though it can take a long time, without this process, consumers could be put at risk. Next slide, please. This concludes my presentation. Up on the screen is our licensing email address for general licensing questions, licensing.questions@mbc.ca.gov. We always encourage potential applicants or programs to reach out with any questions about licensing requirements or the application process, or to request board staff to come out and provide an overview of the process to medical students or residents and walk through their applications with them one-on-one. Thank you very much for your time, and I'm happy to answer any questions.
Thank you, Ms. Connor. Questions or comments on board? Dr. Hauser, and then
Thank you. Ms. O'Connor, I was struck by the fact that we send license issuance emails only every other week. It seemed that'd be a pretty simple thing to do once a license is issued. Why can't we send them on the same day?
It's not an automated process in Breeze, so it's a manual process. But when we have busy times, usually around June, July, August, September, we will send them more often. When we're in those busy times of issuing a lot of licenses and there's deadlines coming up, we'll issue that email almost every day for a period of time to make sure, because people are, when they're up against a deadline, wondering when their licenses are issued.
Given our long timelines for issuing new licenses now, and given the pressures that our applicants face in being able to start work, it would be helpful to shorten that time as much as possible.
Absolutely, yeah. I think, especially considering the backlog, we can look at issuing that email more often throughout the year rather than just at busy times. I know residents don't often have time to check every day online to see if their license has been issued.
Is there a simple tech fix to Breeze for this issue?
We've actually, I don't want to speak for ISB, but there's been a lot of changes made in Breeze ever since the board went on to Breeze, and we're finding new ways we can communicate more directly with licensees and applicants. So we've been looking to identify how else can we automate notifications to licensees and applicants through Breeze. So we are looking through those options and seeing if there's a quicker, more efficient way of doing that.
Thank you.
Welcome.
thank you. Dr. Tsai, before you speak, how many people, if you know, is licensing down in terms of staff? And with
I don't have a percentage off the top of my head, but it's probably representative of what Mr. Verghese shared yesterday, up to that 15 to 20%. It's pretty high.
Okay. That's fine.
Quick question. As you mentioned, it may take up to 6 months. On a good day, clean application, is it 6 weeks? Is it 4 weeks? Is it 3 months? What's the average?
If we receive a complete application at the time of review, so when we're reviewing it, it can be issued in a matter of a week or two. It's very quick. Once those documents are reviewed, it goes through quality assurance, one final check when we issue the license, so it can move very quickly. Expedite applications move, of course, even faster than that. Of course, what's the holdup is the time to initial review, which is taking a long time.
Dr. Blount?
Yeah, thank you so much, and I really appreciate all of the great work you're doing. And one thing I think is important is, can you tell us your observations? You're seeing this firsthand, watching what's happening, hearing what's happening with program directors and applicants. Kind of what are your thoughts? And I do want to just concur that I think that, and Sean and others that are working with you, the automation to take out the manual is going to be critical for the success. But I'd love to hear from you.
Yes, absolutely. It's really communication to applicants, licensees, programs. You know, that there's, with all the new law changes that have been going on, there has been a lot of confusion on how the law applies to specific situations. And there are a lot of different situations that come up, and you have to look at it case by case. Okay, this resident or this applicant in this situation, should they be applying for a PTL? Should they be applying for a physician surgeon's license? Making sure the timing of that works well with the new renewal requirement. Now, it's not just getting your license, it's once I get my license, am I going to be in a position to qualify for renewal? There are a lot of things to take into account, and it is difficult for programs and residents to navigate. That's why we started doing the live webinars and putting them on our website to try to cover a lot of those situations. But there's always questions, which is fine. So we try to be as, you know, as open as we can, myself as well, to any questions programs have to try to navigate through those. And sometimes we get some we haven't seen before, and we have to really look at it and be like, okay, what is the appropriate next steps for this applicant? But communication is one we're trying to improve. Again, not just with the webinars, more outreach to programs, professional associations, but also on the IT side. You know, we're looking at Breeze, of course, has its limitations, but as I mentioned before, we are trying to utilize Breeze the best we can. But we may have to look at something outside of Breeze to add additional functionality that will allow applicants to see more information about the status of their application. That's a huge limitation of Breeze. It's very limited in the I guess you would call them statuses of the application as it moves through the review process. We're hoping to expand on that so they can see more details. Also, possibly a way to communicate quicker rather than via email. I know messaging is a big, I don't know if, you know, I might be going outside my realm here, but, you know, maybe there's, you know, messaging functionality we can look at, but communication is a big part of that. And unfortunately, Breeze doesn't offer a whole lot of information on your application status. And we don't want it to be manual either, because that takes the reviewers away from reviewing the applications. But we understand as well, these are very critical timelines and deadlines that residents and programs are facing. And so we want to be able to get them as much information as we can timely. So I think it's a balance of doing what we can with what we have, Breeze, unfortunately some manual communication processes, but, you know, trying to expand our outreach in that regard, but also looking towards the future of, might take longer, but, you know, an IT solution where we can offer more information to applicants more immediately. One thing we're also looking at is, which we get a lot of requests for, of course, is applicants wanting us to share their application information with their programs, so programs can stay up to date. Of course, that requires the applicant to provide us that authorization, which right now is in writing, which we can accept electronically, but it still needs to be a signed statement. We're trying to look at how we can build that into the application process so we can get that authorization up front and keep that information in Breeze so we can have the email address and information stored. I don't want to speak too far ahead, but those are the kind of things we're trying to look at, of what we can use Breeze for now, get done early on in the process so we're not having to, you know, request and receive that authorization later on. Again, anything we can get earlier on in the initial review, get that information up front so that we're not having to request it later, because we do get a lot of requests from programs asking what's the status of the app, and we have to then say, well, we need the authorization. It's just, you know, it adds to the back and forth and the time of the reviewers, so we're trying to figure out ways we can maybe more easily get that authorization up front and use it in a more efficient way.
Dr. Thorpe?
Thank you, Mr. Chair. Thanks, Marina, for that excellent, and thanks for all that you do. It's a daunting task, and I'm amazed at how much how complex it is. But I think a couple of comments and then and then a question. One of them is, this idea of educating, of bringing new doctors into our training programs in California is really critical to maintaining the infrastructure of the physician workforce in California. There's lots of evidence to show that people tend to stay and practice in locations close to where they were trained. Certainly in the state, there's lots of evidence to show that that's the case. So if we can retain our quality talent in our programs in California and attract people from out-of-state programs to complete their program training in California, that's all excellent stuff. But of course, it all requires the processing of PTLs and the advancement to physician and surgeon license. And I have a very limited view of, or very limited understanding of what all is required. But it seemed to me that in this period of time when we were dealing with this PTL kind of onslaught because of the change in law, that there was a lot of confusion in the program directors' minds. Of course, the applicants were even more confused. Even we were a little bit confused at times because we weren't always sure exactly what needed to be done. As we're going forward with the new recommendations of the PTL lasting 36 months as opposed to whatever it has been in the past, what are your number one, your expectations about how this process can be smoothed out and hopefully not see these catastrophic sort of situations where people have days to get their licensing straightened out before they have to be terminated by their plant program because they don't have a license to practice? That number one. And then well, I guess number two, do you see that if we do that will actually kind of smooth things out and get us on a track where you're not, just frantically trying to respond to individual requests periodically?
Can I ask you, is that a question that is approved for the next item or no?
I mean, I was going to make that part of my response,
Okay.
but I think I can still answer it because I kind of see it in two ways. One is, again, what can we do in our processes to streamline it? We've been looking with a fine-tooth comb through our processes. There's been some licensing updates at previous board meetings regarding mapping our business processes. We've actually just completed the project. So we first mapped all of our current business processes, and then we mapped what we want them to be, basically. What could they be if we had our perfect world of, IT, ability and streamlining processes and all that. So we're now going through our could-be processes, and we're looking at what can we make today? What changes can we make today to get there? And what are those changes that, yes, will require more time, probably, maybe an IT solution or something else has to be developed. It may take more time, and we can work on that. At the same time, or we can make those steps today, anything we can cut down on. There's a lot of printing, there's a lot of paper. We can go paperless for the applicant, but we really should be going paperless in our internal processes as well, because paper can be lost. Paper has to be filed. It has to be manually processed. So if we can have everything in one system, everything we need, it can be streamlined. So I think that's one approach, is streamlining our processes, getting our review times not only down, but that will help speed up the review, but also maybe even decrease deficiencies. And then two is, as Dr. Hawkins mentioned, we'll probably cover part of that in the next agenda item, but it's also in our sunset report. A lot of the law changes have created deadlines, short deadlines, that can put a lot of residents in a bind trying to meet licensure requirements without running up against having to cease training. And so I think the proposals in our sunset report, and one of the ones we'll discuss in our next agenda item, is through that lens of does the timeline really need to be this length? Can we make it longer? What can we do to keep it, to help it flow better so that we don't have folks in that situation where their PTO is about to expire, or whatever the deadline is coming up, and they're not, it doesn't look like they're going to get a license in time, right, even if we did everything we could to move it along. So we want to avoid those situations, both for the residents, for their patients, for the board as well. It really benefits all to not have such short timeframes and make sure there's ensure that continuity of care, make sure that they're not having to cease training that can mess up so many things on so many levels. So I think part of that will be in the next agenda item.
Thanks, board members. Are there comments or questions from those in the room? WebEx?
Hand raising feature in the Q&A window open for anyone wishing to make a public comment. Calling users, you can press *3 in order to toggle your hand as well too. Give everyone a few seconds here to see if anyone queues up. Not seeing any requests, Dr. Hawkins.
Thank you. Our next agenda item is 13, discussion and possible action on the requirement of successful progress through 24 months of postgraduate training in the same program for initial renewal of physician surgeon license. Ms. O'Connor.
Okay, thank you again. Effective January 1, 2022, BPC Section 2097A requires physicians and surgeons licensed on or after January 1, 2022 to provide proof of credit for 36 months of board-approved postgraduate training, including successful progression through 24 months in the same program, as a condition of their initial renewal. Prior to January 1, 2022, this was a requirement for initial licensure as a physician surgeon. Leading up to the board's decision to propose this licensure requirement in its 2016 Sunset Review Report, the board discussed concerns with residents changing postgraduate training programs and not completing a program due to performance issues, but still qualifying for licensure. The successful progression through 24 months of training in the same program was included in the licensing requirement to encourage remediation of performance issues within the program where they were identified. When the 24 months in the same program requirement became an initial licensure requirement on January 1, 2020, the board began receiving concerns from applicants and postgraduate training programs regarding residents that were unable to complete 24 months of continuous training in the same program due to factors outside of their control, such as program closures or relocating to care for a dependent. Under the prior law, however, the board was able to extend the PTL to allow the applicant time to complete this requirement. Under the current law, licensees must provide the board proof they meet this requirement within 60 days of their license expiration or risk no longer being able to practice in California. Applicants and licensees that may not meet the 24 continuous months requirement have been referred to the Application Review and Special Programs Committee for a recommendation on whether their postgraduate training is substantially compliant under BPC Section 2097C. Recently, the ARSPC has considered requests from residents that have not yet completed their postgraduate training but are considering transferring to another program and want to ensure their training will be accepted by the board to meet the renewal requirement. Board staff anticipate receiving an increase in requests from licensees who either do not meet the 24-month initial renewal requirement or are planning to transfer programs before they complete 24 continuous months in the same program, all of which will have to be submitted to the ARSPC for review and recommendation. Licensees without any performance issues face constraints when deciding whether to transfer to a new program before completing 24 continuous months. California is currently experiencing a shortage of physicians and risks losing qualified physicians to other states if they are unable to meet renewal requirements or have the flexibility of changing programs. Staff recommends the board discuss and consider approving one of the following changes to BPC Section 2097. 1, remove the requirement under BPC Section 2097A that a licensee must obtain credit for successful completion of 24 months of board-approved training in the same program in order to renew their license the first time. Or 2, specify criteria for when a licensee is exempt from obtaining credit for successful completion of 24 months of training in the same program, such as a resident that does not have any disciplinary or conviction history and no performance issues identified by previous training programs. And I'm happy to answer any questions.
Any comments or questions from the board?
Dr. Hawkins?
Oh, yes, sorry, please.
Sorry, thank you. You know I'm going to have a question about this. Yeah, so can you go back over the two choices again? Because the one comment I wanted to make with your last presentation and this one is there's a lot more residents and fellows than there are DIOs and program directors. So the level of accountability and oversight for a trainee rests with ultimately their program director and then upstream to the DIO, whoever the sponsoring institution is, to see and train the oversight. So you have a block of being able to get information until there's a signature. You know, is there something that could be looked at where legislation that would say, you know, if you're in a program, you're under the umbrella of your DIO and your program director, just to make that transition easier. But of the two choices, now moving forward with what you're talking about now, can you give us the upsides and downsides of choice A or B?
Sure. So in choice A or 1, which I'll just say again, is to remove BPC section 2097A from statute, which right now requires a licensee to complete 24 months of board-approved, to obtain credit for 24 months of board-approved training in the same program in order to renew their license for the first time. So when the license is issued, it's issued for 2 years. So essentially, they would have 2 years from the date their license is issued to obtain 24 months in the same program. The upside to removing that is it wouldn't be a barrier for those who can't meet the 24-month requirement due to circumstances outside their control. These are not performance issues. These are not folks who are need extra time in a program or have struggled through one program and transferred to another and then transferred to another, and help retain the physicians we want to retain in California. But it also, you know, going back to the initial reason for the 24-month requirement that was put or recommended and proposed by the board back the 2016 sunset review process, it was seen as an attempt to make sure that residents are completing their program, remediating their deficiencies before they obtain a license. You know, make sure that training, and again, that was also when it was 36 months were required to obtain a license. So it was hand in hand with the 36-month requirement that of those 36 months, 24 should be completed in the same program. So, you know, that would no longer be required. So a resident could complete, you know, 1 year here, 1 year in a second program, and 1 year at a third program and still renew their license. And option 2 was keep that requirement in statute, but specify specific circumstances when someone could be exempt from it. I only gave one example in the write-up, which was a resident that doesn't have any disciplinary or conviction history and no performance issues identified in their training program. I think the only issue with that is, you know, you have to come up with a specific criteria, and there could be a lot of different situations where you want to exempt someone. And so if you put that in statute, it's going to be very specific. These are the only situations where we can exempt someone. So, and I don't know, sorry, if Carrie, you want to add anything to the pros or cons, but those are kind of the things that come to my mind.
I think you hit it.
Okay.
The legislature made these changes over the board's objections, and now we're trying to figure out how to work with it.
Dr. Hauser and then Dr. Tsai.
Thank you. So I agree that looking at performance issues identified in a training program is pretty broad. Do we have access to things like clinical competence evaluations that are submitted by the program to, say, a certifying board? Would that be a possible proxy for this measurement?
We don't ask for that up front. The only situation I can think of where we would ask for something like that would be one if we if we knew there were competency issues and that was part of their resident file, and we were, you know, because of the issues identified during training, we requested the resident file, and there was maybe a note regarding a competence evaluation performed. I suppose we could ask for that, but it's not something, it would only be if we knew about it and there was a reason to
For a
request.
resident to become board eligible, they have to have a satisfactory competence rating at the end of their training. That might be something that we could use to exempt them from this requirement.
That's right.
Yeah, I think, you know, you working in the trenches on a daily basis, I think option one would give you more latitude, whereas option two, we would have to come up with a laundry list of all the things that we deem appropriately. And of course, somebody will be outside of that list. So with respect to that, I move that we adopt recommendation number one so that we can move forward.
Is there a second?
Second.
Okay. Comments in the room?
Hello, everyone. Lucas Evanson with the California Medical Association. CMA would like to thank the board for including this item on their agenda and the board for their excellent analysis of this issue. We would like to keep our comments brief to allow other interested stakeholders to have the opportunity to share their experience. Therefore, CMA will just share that it believes this requirement acts as an impediment to highly qualified residents entering the state and choosing to practice in California. So CMA asks that the board move to remove the requirement that a license must obtain credit for successful completion of 24 months of board-approved training in the same program in order to renew their license the first time. Thank you.
WebEx.
If anyone wants to make a public comment, you can go ahead and raise your hand or use the Q&A box and type something in there. We'll call you on you in the order we see you. First up here, we have Dina McRae. Dina, let me find you. All right, Dina, you should be receiving that request on your end.
Thank you very much to Ms. O'Connor and her team for analysis of the 24-month rule, and thank you to the board for allowing time for comments. I'm Dina McRae from University of California, Office of the President. The University of California Health System respectfully requests elimination of the requirement for a resident to be in the same training program for 24 months. Option one, there are many scenarios when a resident in good standing may not complete 24 months of training in the same program. For example, a resident in a 3-year family medicine program may need to transfer to a different program in the middle of the second year of training. Possible reasons could include a program closure, a partner's job change, childcare needs, or caretaking responsibilities of a loved one in a different geographical area, or residents may want to relocate from a state with bans on abortions or gender-affirming care to the state of California, where they can both provide as well as receive comprehensive evidence-based care. The Accreditation Council for Graduate Medical Education has requirements regarding the selection process of residents, as well as continuous competency assessments to optimize patient safety and protect our communities. Programs must verify previous educational experience and review performance evaluations prior to acceptance of any transferring resident. Once accepted, 360-degree evaluations must be continuously collected, and formal assessments must be performed semi-annually at minimum by a clinical competency committee, with these evaluations being directly submitted to the ACGME for each resident. Non-compliance would impact accreditation status of the program and institution. Thank you for considering the elimination of the 24-month rule, option one.
Thank you for your public comment. Next up here, we're going to go to Susan Grolnick. Susan, you should be receiving that prompt. We can, Susan. Please go ahead.
Okay. Thank you. I would like to thank the board for putting this important item on the agenda and the staff for their careful analysis. I am the Associate Dean for Graduate Medical Education and DIO at UC Davis. We request that the licensure renewal requirement for 24 months of continuous training in the same program be removed. The requirement has no value as a marker of competence and at times prevents qualified physicians from practicing in our state. Each of physicians in training are negatively impacted by the 24-month rule. I would like to tell you about a current resident at UC Davis. After medical school, this young physician matched into the UC Davis radiology residency program. Physicians training in radiology are required to do 1 year of training in clinical medicine, and he began this training in an out-of-state internal medicine program in July of 2021. 7 months later, one of his parents became seriously ill, so he withdrew from that program and deferred his radiology training so that he could return to California to care for his ill parent. He was able to secure a new 1 year clinical training experience as required and began training in surgery at UC Davis in July of 2022. Per current board policy, his 7 months of internal medicine training were counted toward his postgraduate training license duration, and he was required to transition to a full license in March of this year. At the end of June, this physician will complete his surgery training in good standing and enter the radiology program. He will have had 7 months of training in internal medicine and 12 months of training in surgery. His California medical license will be due for first renewal in March of 2025. However, at that time, he will be 4 months short of meeting the California license renewal requirement for 24 months of consecutive training in a single program. This young physician did what I wish my own children would do, and as a result, under current policy, would not qualify for license renewal in our state. Not because he lacks competence, but because of an assumption that 24 months in a single program implies competence. We should want physicians in our state with that kind of compassion, willing to delay or risk their dreams to do the right thing for those they love. That compassion will translate to the care of patients and their families. Those that train these physicians take this responsibility seriously. There are mechanisms in place to provide oversight and assessment that ensures patient safety, enabling them to attest to the physician's competence based on observed performance rather than duration of training. We request that the requirement for 24 months of continuous training in the same program be removed from the licensure requirements. Thank you for the opportunity to speak.
Thank you for your public comment. Next here we'll go to Daniel J. Daniel, you should be receiving that prompt.
I am the DIO and Associate Dean for Graduate Medical Education at Loma Linda University Health. Thank you very much for considering this issue. I want to speak in favor of option number 1 as is on the table. And I want to give a little anecdote that illustrates Ms. O'Connor's presentation. One of our current residents started her training in OBGYN in a hospital in Illinois. In December of 2020, when she had completed 18 months of training there, it was announced that their program was closing because of financial reasons, and that they needed to find a new residency program to start on January 1. This obviously caused the residents a lot of stress, including the resident who wanted to come to Loma Linda. She was very concerned not to have to, again, switch programs at the end of 36 months, which was certainly a possibility based on the current way the statutes are written, and was not going to come to California. As it turns out, she was an osteopathic graduate, and the osteopathic medical board provided her within 48 hours of a waiver, written waiver, assuring her that she would not be held to the 24 months in one program stipulation. And based on that, she happily came here. She was not only thrilled to be able to come to California to complete her training, she actually talked one of her other residents into coming with her to California. And so we, as the state, got 2 extra OBGYN physicians who are very likely, as was pointed out, to stay in our state after graduation. As Ms. O'Connor pointed out, this originally made sense in the context of the 36-month PTL, but that is no longer true. And so we certainly believe that at the way it is currently structured, the only thing that the 24-month statutory limitation does is make people who would want to come to California for their continuation of training think twice and perhaps go to a different state. Thank you very much for your consideration.
Thank you for your public comment. Next up here we have Dennis. Dennis, you should be receiving a prompt on your end.
Afternoon, Medical Board members. Dennis Cuevas Romero. I'm the Vice President of Government Affairs at the California Primary Care Association. We represent the community health centers in the state. I want to thank the Medical Board and staff for their thoughtful analysis on this issue, and we certainly recommend the board to approve recommendation 1 to eliminate the 24-month CPCA was part of a coalition that advocated for the removal of this item 2 years ago during the medical board sunset review process, and we encourage the board to approve option 1 recommendation for all the challenges that this has caused residents that are highly qualified, and want to make sure that we provide the residency directors the autonomy to make those decisions. So again, are thankful for the medical board for their analysis and hope you approve recommendation 1. Thank you.
Thank you for your public comment. Next up here, we have Katrina Reyes. Katrina, you should be receiving that prompt. There you go, Katrina. Looks like your line's open.
Oh, okay. Sorry, I just received the prompt. Sorry. Good morning, Katrina Reyes with the California Academy of Family Physicians, the largest primary care medical society in California, representing more than 10,000 family physicians, residents, and medical students, including the residence program directors and DIOs in 67 family medicine residency programs in California. We'd like to thank the board for putting this topic on the agenda, and we'd also like to thank board staff for their analysis on this issue. We support the recommendation to remove the requirement under BPC Section 2097A that a resident must obtain credit for successful completion of 24 months of board-approved training in the same program in order to renew their license for the first time. As the analysis stated, licensees without any performance issues face constraints due to this requirement. For example, one of our family medicine residency programs in an underserved community was expecting to hire a fellow from out of state who has been in excellent standing throughout her training. But because she transferred programs in the middle of her training due to her partner's serious health condition and was unable to extend her training because the program did not have the funding for the additional time, she was unable to meet California's strict 24-month requirement in the same program, and thus was unable to be licensed in California. She is now employed in another state rather than coming to serve in one of our underserved communities. As the analysis also stated, California is currently experiencing a shortage of physicians. By 2030, California is projected to have a shortage of over 4,000 primary care clinicians. The analysis further states that California risks losing qualified physicians to other states if they are unable to meet the 24-month requirement or have the flexibility of changing programs. Just from the example I provided and the examples that you've heard before me, we know that it's no longer just a risk, but a reality that we are losing qualified physicians to other states. Accordingly, we urge the board to accept recommendation 1 so we may begin to address the workforce shortage and increase access to care for all Californians. Thank you.
Thank you for your public comment. This time, Dr. Hawkins, I'm not seeing any additional requests. Sorry, Dr. Hawkins, can we bring the room audio back on?
Okay, I move to adopt option number 1, and
Yeah, and I seconded.
Sorry, call the roll.
Ms. Lubiano?
Yes.
Dr. Bolat?
Yes.
Dr. Hilzer?
Yes.
Ms. Jung?
Yes.
Dr. Mahmood?
Yes.
Mr. Rue?
yes.
Dr. Thorpe?
Yes.
Dr. Tsai?
Yes.
Mr. Watkins?
Yes.
Dr. Hawkins?
Yes. Thank you very much, Mr. Connor. Appreciate you. Now I move to item number 14, update and possible action related to Midwifery Advisory Council. Ms. Wisner. Is she behind that pole? I don't see anyone.
She's online with us.
Oh, great. Excellent. Thank you. Welcome, Ms. Wisner.
Hi, thank you. Can you hear me okay?
Yes.
Hi, I am Madeline Weisner. I am a licensed midwife and the chair of the Midwifery Advisory Council. I am pleased to provide you with an update on the MAC and will be requesting a motion to appoint 2 new MAC members and to approve agenda items for the next MAC meeting. The last MAC meeting was held on March 30th, 2023. At this meeting, the following actions were taken, or the MAC was provided the following information. We approved meeting minutes from the January 5th, 2023 MAC meeting, received an update from the MAC chair, discussed the goals for the MAC, received an update from the task force on Medi-Cal related issues, received an update on the proposed regulatory language for the Licensed Midwife Annual Report, also known as the LMAR, received an update on midwifery legislation and sunset review, received an update on the midwifery program, discussed the LMAR reminder letter and worksheet, discussed midwifery school application information listed on the board's website. We also voted on appointment of officers on the MAC and voted to recommend to the board 1 licensed midwife and 1 licensed physician for the vacant positions on the MAC. Please turn to agenda item 14A and B for the MAC materials. The board received 1 application for the licensed midwife position and 1 application for the licensed physician position. Both of the applicants were present at the March 30th, 2023 MAC meeting and addressed the MAC regarding their interest in becoming members of the MAC. The council voted to recommend to the board appointment of Mason Wilson Tanev, a California licensed midwife, to the vacant licensed midwife position, and Dr. Kenneth James, a California licensed physician, to the vacant licensed physician position. Additionally, the MAC is requesting approval of the following agenda items for its next MAC meeting. Approval of minutes from the March 30th, 2023 MAC meeting, report from the MAC chair, establishing goals for the MAC, report from the task force on Medi-Cal related issues, update on proposed regulatory language for the licensed midwife annual report, update on midwifery related legislation and sunset review, update on the midwifery program and LMAR, selection of 2 new MAC members, 1 licensed midwife and 1 public member, appointment of officers of the MAC, overview of the enforcement process, discussion on birth certificate and social security registration issues, discussion on midwife access to screening equipment for newborns, discussion and possible action regarding 2024 Midwifery Advisory Council meeting dates. May I please have a motion to approve Mason Wilson Tanev's appointment to the MAC and to approve Dr. Kenneth James' appointment to the MAC and to approve the requested agenda items for the next MAC meeting?
So moved. Thank you very much for the approval in a second. Thank you, Ms. Wisner. Any comments from the board? Any other comments from the board? Any comments from public in the room? On WebEx?
Hand raising feature in Q&A window open for anyone wishing to make a public comment. First request here is from Rosanna Davis. Rosanna, let me send you that invite. Rosanna, are you there? Looks like your line's open.
To request be added to the agenda for the upcoming MAC meeting. I don't know if that follows process or not, but I thought I'd throw it in there. I've discovered some discrepancies in our licensed midwife annual reporting data collection tool. Therefore, I'd like to request an agenda item to address the problems and request that a task force be formed to create that problems. I have public comments as follows. Hearing the controlled substances guidelines discussion was enlightening. The medical board was unable to promulgate practice guidelines for licensed midwives as instructed by AB 1308 in 2014 because of the ongoing regulatory capture of the medical board by CMA and ACOG. Despite several interested parties meetings, the medical board did not promulgate regulations without consensus from medical association stakeholders because evidence-based guidelines protecting public safety would be in conflict with ACOG and CMA opinions not based on evidence related to midwifery care and community birth. In those interested parties meetings, ACOG was asked for evidence to back up their opinions, and ACOG was never forthcoming. So here we are 10 years later without guidelines put through proper administrative process, and therefore the medical board being subjected to using underground regulations and holding midwives to medical standards of practice in disciplinary cases against midwives. In 2017, subsequent to the regulatory stalemate, the medical board, with thoughtful assistance from Dr. Bolat, thank you, proposed a legislative remedy to the regulatory stalemate. However, that legislative remedy was sabotaged by the parallel introduction of hostile legislation by ACOG and CMA, which was Bates 457. And so that legislative fix did not go through. Licensed midwives and the clients we serve urgently need, at minimum, a committee with regulatory and disciplinary authority under the medical board, but ideally an independent licensed midwife board. That concludes my comments. Thank you.
Thank you for your comments. At this time, Dr. Hawkins not seeing any additional requests.
Thank you. Ms. Miller, will you please call the vote?
Ms. Lubiano?
Yes.
Dr. Bolat?
Yes.
Dr. Hilzer?
Yes.
Ms. Jones?
Yes.
Dr. Mahmood?
Yes.
Mr. Rue?
Yes.
Dr. Thorpe?
Yes.
Dr. Sy?
Yes.
Mr. Watkins?
Yes.
Dr. Hawkins?
Yes. Next, item 15, discussion and possible action to amend Title 16, California Code of Regulations, sections 1364.10 and 1364.11 regarding citations and fines. Ms. Webb.
Thank you, members, and I will say at the end, I will propose suggested language for a motion to hopefully simplify this. Please turn to item 15 in your materials. And you may recall that we discussed the cite and fine regulations in December, where you approved modifications to the text to update and streamline the board's cite and fine regulations. I made some additional modifications to refine and streamline the language to provide further clarity that it applies to all of the board's licensees, certificate holders, and registrants. Additionally, I removed further redundant language and also made room for code sections that have different fine limitations and factors for review when determining the appropriate level of fine. I came across some additional sections that I hadn't seen the first time around that had their own limitations in those particular statutory sections. So I believe the fix will address any others that may be applicable so it doesn't get kicked back. That's the hope. So the proposed amended language is attached to the materials, and I am asking for a motion to do the following. First, approve the text. Second, direct staff to prepare the necessary regulatory documents to submit to the Department of Consumer Affairs and the Business Consumer Services and Housing Agency. Third, upon DCA and agency approval, submit the documents to the Office of Administrative Law to notice the proposed regulatory language to amend sections 1364.10 and 1364.11 of Division 13 of Title 16 of the California Code of Regulations. And fourth, if no substantive adverse comments are received during the 45-day comment period, authorize staff to finalize the rulemaking file and submit it to DCA and agency, and upon approval, to the Office of Administrative Law, and to make any technical or non-substantive changes without returning to the board. May I have that motion?
So moved.
I second.
Do any members have any questions or comments? Questions or comments from the room? WebEx.
Q&A window and hand-raising feature are available for anyone wishing to make a public comment. Give everyone a few seconds here to queue up. Not seeing any calls, Dr. Hawkins.
Okay. Ms. Moriarty, please call the vote.
Ms. Lubiano?
Yes.
Dr. Bolat? Dr. Hilzer?
Yes.
Ms. Jung?
Yes.
Dr. Mahmood?
Yes.
Mr. Rue?
Yes.
Dr. Thorpe?
Yes.
Dr. Sy?
Yes.
Mr. Watkins?
Yes.
Dr. Hawkins?
Yes. Thank you.
Thank you.
Thank you, Ms. Webb. The next future agenda items, I would advise members that are working and will anticipate completing a presentation on maternal mortality and morbidity at our next quarterly meeting in August. Do any members have any future requests for future agenda items? Dr. Hauser.
Thank you. I'd like to ask that we set our 2024 meeting schedule at our August meeting.
Okay. Others? Yes, Mr. Watkins.
I would like to have the 14-point plan that I suggested at the December meeting be discussed at hopefully before my term runs out.
Others? Dr. Bernard? Jesus Christ.
It's okay. I'm interested at some future meeting talking about artificial intelligence and the intersection with medical practice.
Yeah.
Kind of, whose documentation is it?
Thanks for that. Ms. Liana?
That's a good one. Thank you. And also to Dr. Hilzer, good thinking forward, you know. So thanks for that. When we talked about our strategic plan, we as a board implemented an item about diversity, equity, and inclusion in there as part of board administration. And so I know that Mr. Varghese is on the committee, steering committee with DCA. And so I'd like to get an update or an overview of, you know, where we are specifically at the medical board on that, and learn about some of the things you might be looking at, Mr. Varghese, and some ideas on how we can implement that into our board and strategy. Thank you.
Thank you very much. Anyone else before we go into the room and WebEx? Anyone in the room with suggestions for a future item? WebEx?
In the hand raising and the Q&A feature are available. Anyone wishing to make a public comment, suggest a agenda item for here? First up here, we have Marianne Hollingsworth. Marianne, you should be receiving that prompt.
Hello, can you hear me now?
We can. Please go ahead.
Hello, I'm Marian Hollingsworth, patient safety advocate. I would just like to suggest that the board review the idea of having a regular advocate meeting like we were there for a while. I know they kind of fell apart, but it would be nice to get that back on track, and maybe with an advisory group kind of streamline it to more relatable things that both sides could work together on. So if you could have that, that would be greatly appreciated.
Thank you.
Thank you for your public comment. At this time, Dr. Hawkins, I'm not seeing any additional requests.
Thank you very much. We're next supposed to go into closed session. I wonder if we could take a 15-minute break, bow break, and before we go into Item number 17, which is closed session. Pursuant to Government Code 111126, the board will convene in closed session to discuss and make possible actions to appoint an executive director. And after that, the plan would be to adjourn unless there's a reason to reconvene in open session. So may a 15-minute break, please?
Thank you, Dr. Hawkins. I would like to point out to the remote attendees, when we do go into closed session, we'll be ending the open session with no plans to adjourn for, or to come back for adjournment, since that's the only remaining item on the agenda. It's just a limitation of the room that we need to use for closed session as well.
Adjournment. So we won't be returning for open session. There will be no further business discussed in open session unless there's some reason that we can't foresee.
That's correct. Yeah, to use the room for the closed session, we're going to have to shut down the open session. Thank you very much. So we'll be putting on a slide about being on break for about 15 minutes. Dr. Mahmood will be opening that closed session. We'll see you over there at approximately 12:35-ish. Okay. Thank you very much.